Hello everyone. In this session, we are going to discuss an ultra important topic, that is carcinogenesis. So I will be discussing three types of carcinogenesis: physical, chemical and biological. Out of the three carcinogenesis, you usually get a short question on the physical carcinogenesis, that is radiation induced carcinogenesis, and you get a long question on chemical and biological, that is virus induced carcinogenesis. So let's start it. We will be covering all three one by one. So let's start the topic. You can see it here. We are starting the topic carcinogenesis, physical, chemical and biological. So first of all, I will let you know what do you mean by carcinogenesis. What are carcinogens and what do you mean by carcinogenesis? After that, we will be seeing the detail of the three types of carcinogenesis one by one: physical, chemical and biological. I will let you know all three carcinogenesis one by one. In the physical carcinogenesis, we have two types of radiation induced carcinogenesis: UV light and IR light. So we will be having a look at both of them. So let's start it. So let me tell you what is carcinogenesis. Now I told you, you can see this is a cell. You can see this is a cell. Here, when the growth factor is coming, the cell does the mitosis. When no growth factor is coming, the cell do not do the mitosis because of the two genes. I guess you have already watched my video on proto-oncogene or tumor suppressor gene. If you have not watched it, please do it right now. Before this session, you must watch that session. Okay. So there is a gene which is known as proto-oncogene. The proto-oncogene and tumor suppressor gene. Proto-oncogene is a gene that promotes mitosis, that does the mitosis, that induces the cell division. And tumor suppressor gene is a gene that inhibits the mitosis. So I always call the proto-oncogene as the accelerator, and I always call the tumor suppressor gene as the brake. So if you are driving a car, if I want to increase the speed, I will apply the accelerator. And if I want to reduce the speed or I want to stop the car, I will apply the brake. So there is a balance in the speed. So whenever I want to increase the speed, I can apply the accelerator. I want to decrease the speed or stop the car, I can apply the brake. So my speed is under control. So it's the same way happens in the body also. Whenever the body wants to do the cell division, the proto-oncogene comes in a role. And whenever body do not want to do the cell division, the tumor suppressor gene come in a role. So these both are normal genes and there is a balance in the body. But imagine you are driving a car in which the accelerator, the car is defective. The accelerator is stuck at the highest speed, or the brake is not functional, the brake is failed. So what will happen? You cannot reduce the speed because the accelerator is defective. It is stuck at the highest speed. And the brake is also defective. It's non-functional. So there is uncontrolled speed, uncontrolled mitosis, and that leads to cancer. What is cancer? It's uncontrolled mitosis. So here the proto-oncogene is mutated and it becomes overstimulated. And here tumor suppressor gene is also mutated and it becomes understimulated or inactivated. So that leads to cancer. I guess I have already explained you this in the proto-oncogene and tumor suppressor gene portion. You already understood this. Why I'm telling you this again here in this carcinogenesis? So there is mutation of proto-oncogene and mutation of tumor suppressor gene. The mutation, because of the mutation, I highlight the word mutation. Because of the mutation of proto-oncogene and tumor suppressor gene, they become defective. The tumor suppressor gene become underactive and the proto-oncogene become overactive. So the mutation is causing the defect. You must think there may be a question in your mind, who is causing this mutation? The agent which caused the mutation is known as carcinogen. It can be a physical agent, it can be a chemical agent, it can be a biological agent. And the mechanism of induction of the mutation is known as carcinogenesis. So basically, carcinogenesis is the mechanism by which the mutation occurs in the tumors. The mutation. And carcinogens are the agents which causes the mutation. The gene can be proto-oncogene. The gene can be tumor suppressor gene. Gene can be anything. But the agent which is causing the mutation in the gene, that is known as carcinogen. And there are three types of carcinogens. They can be physical agents, chemical agent or biological agent. They induce mutation in gene. Mutation in genes. Which genes? Either they can be proto-oncogene or tumor suppressor gene. They can be the accelerator, they can be the brake. So mutation leads to the cancer. So these are important for causing cancer. So one by one, we will see the detail. This is the introduction, this is the definition. So what is the definition of carcinogens? What is carcinogen? And what is carcinogenesis? Can you tell me what is carcinogen and what is carcinogenesis? Carcinogens are the agents which induces the mutation. They can be physical, chemical, and biological. And the mechanism by which this mutation occurs by these agents is known as carcinogenesis. So it is basically the mutation. So one by one, we will have a look on all of them, the three types. Let's start with the first one, physical carcinogenesis. Physical carcinogenesis is radiation-induced carcinogenesis. Here, the radiations are causing the mutation. There are two types of radiation, UV light and IR light. UV is ultraviolet light. IR is ionizing radiation light. So UV light and IR light are the two types of lights that can induce the mutation and that can lead to the cancer. So one by one, we will see the detail. Let's start with UV light. Let's start with UV light. Now you have to tell me three things for both of them. First, tell me the source. From where this light is coming. Then tell me the mechanism by which it's causing the cancer. And tell me enumerate the cancer in human body. Which cancers does it cause? So first tell me the three things for UV light. Tell me the source of UV light. Tell me the mechanism by which UV light induces cancer. And tell me the cancer. Which cancer it causes in human body. The same three things you have to tell me for the IR. In the end, we will compare them. Okay, let's start with UV light. UV light. From where we get UV light? So UV light comes from the sunlight. You can see it is coming from the sunlight. UV light is present in the sunlight. In the sunlight, there are three types of UV light. UVA, UVB, UVC. Based on their wavelength. Their wavelength is different. UVC have small wavelength, minimum wavelength. 200 to 280 nanometer. UVB is 280 to 320 nanometer and UVA is 320 to 400 nanometer. If you want to learn, if you can't learn, it's okay. It's okay. There are three types of UV light. You have to learn that. Now see, this is Earth. Over the Earth, we have ozone. I guess everyone knows Earth is surrounded by ozone layer. So this is ozone layer which is surrounding the Earth. And this is sunlight. You can see this is sunlight. From the sunlight, three types of UV lights are coming. UVA, B and C. C don't reach the Earth because it is filtered by the ozone. C don't reach the Earth. From A and B, they both reach the Earth. So A is also coming to the Earth. B is also coming to the Earth. But A is good. It is required for vitamin D activation in our skin. Okay. But B is bad. You can learn B for bad. B is carcinogenic. It induces cancer. So UVB is bad. You usually get an MCQ on that. So out of the three UV light, first thing you have to learn, UV light is coming from the sunlight. There are three types of UV light, UVA, UVB, UVC. Okay, C do not reach the Earth because it is filtered by ozone. Now out of A and B, the B is carcinogenic, B is bad. A is good, B is bad. It is carcinogenic. Now A is good. You can see from the sunlight, UVA is required for activation of vitamin D. The activation of vitamin D, A is required, but B is bad. So if UVB, A is good, B is bad. A is required for activation of vitamin D. B induces cancer. B is carcinogenic. It can induce cancer. So how does it induce cancer? So let me draw a skin cell. You can see this is skin. So UVB is coming on the skin. So this is the skin cell. You can see the cell of the skin. You can see the cell of the skin is there. This is the nucleus of the cell of the skin. In the nucleus, we all have DNA. We know DNA is a double-stranded molecule. This is a double-stranded molecule. Now, what is there in the double-stranded? Purine form bonds with pyrimidine. And pyrimidine form bonds with the purine. I guess everyone knows that. You have read this in biochemistry. I guess everyone knows. So this is normal. Purine form bonds with pyrimidine. Pyrimidine form bonds with purine. So this is the double-stranded DNA molecule. Now, when the UV, when this is exposed to sunlight, when the skin, this is the skin cell, all the skin cells, when it is exposed to sunlight. So from the sunlight, UVB is coming. This UVB will come and hit the nucleus of the skin cell. It will hit the nucleus of the skin cell and it will form pyrimidine-pyrimidine dimer. Pyrimidine-pyrimidine dimer. Normally, pyrimidine-pyrimidine dimer is not there. Purine form bonds with pyrimidine. But because of UVB, pyrimidine-pyrimidine dimer is formed and that portion is mutated. So whatever gene is presented here, that is mutated. On the DNA, whatever gene presented here, that is mutated. So UVB causes pyrimidine-pyrimidine dimer formation. What does it do? UVB causes pyrimidine-pyrimidine dimer formation. Pyrimidine-pyrimidine dimer formation. So this is the mechanism. So whenever UVB is coming on the skin cell, it forms pyrimidine-pyrimidine dimer and that leads to mutation. And that leads to cancer. So this is the mechanism. In the mechanism, you have to learn one line. Pyrimidine-pyrimidine dimer formation, you have to write it. Okay. Now name this cancer. It causes only skin cancer. So UV light causes only skin cancer. Skin cancer. Three types of skin cancer. Most commonly basal cell carcinoma of the skin. So which is also known as rodent ulcer. The second is squamous cell carcinoma and third is melanoma. So basal cell carcinoma, squamous cell carcinoma and melanoma. These are the three skin cancers can be caused by UV light, UVB. Most common among them is basal cell carcinoma. So we are done with the UV light. So in the UV light, we have seen three things. You have to tell me three things for the UV light. Tell me its source, tell me the mechanism by which it causes cancer, and enumerate the cancers which it is causing. So tell me the source. You all know the source is the sunlight. In the sunlight, three UV light are present, UV A, B, C. But B for bad, you will never forget now. B for bad, that is carcinogenic. A and C are not carcinogenic. Mechanism, it causes pyrimidine dimer formation that leads to mutation. And in the cancer, it causes only skin cancer, the three type of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. That's it. So that is the UV light. Okay, now coming on the IR. In the IR light, what is the source? Can you tell me the source? It can be X-ray, gamma ray, alpha ray, beta ray. X-ray, gamma ray, alpha ray, beta ray. It can be the source. It is not sunlight. It is not coming from the sunlight. It can be coming from either X-ray, alpha ray, beta ray, gamma ray. What is the mechanism? Now, this can be any body cell, not skin cell. It can be any of the body cell. Maybe it is a blood cell. This is the nucleus, inside which this is the double-stranded DNA. Okay, now in the cytoplasm, we all have water. In the cytoplasm, the water, HOH, H2O, water is present in the cytoplasm of all human cells, right? Now when IR, ionizing radiation, is falling on the cell, ionizing radiation is not of three types, it is of only one type. When it is falling on the cell, what does it do? So the water which is present in the cytoplasm, that water will convert it into free radicals. What are the free radicals? It will convert it into hydroxyl ion, it will convert it into superoxide ion, it will convert it to hydrogen peroxide. These all are free radicals which are formed from the water. And these free radicals will induce the mutation. They will lead to the multiple mutations in the DNA. So here the mutation is due to free radical formation from the water. So this is the mechanism. So I hope you got it. So here the ionizing radiation which is falling on the cell, that is dislodging the water present in the cytoplasm and forming the free radical. And free radical is causing the mutation and leading to the cancer. Name the cancer. It causes blood cancer. It causes leukemia. How many types of leukemia you know? There are 4 types of leukemia. 2 of them are myeloid, that is CML, AML, and 2 of them are lymphoid, ALL and CLL. Okay, so out of the 4 leukemias, CLL is never caused by IR. The remaining 3 can be caused by ionizing radiation. So it causes all leukemia except CLL. You have to learn the exception. You get an MCQ on that. So all forms of leukemia except CLL. CLL is not caused by IR. Okay. It can cause all type of thyroid cancers also. There are 4 types of thyroid cancer: papillary, medullary, anaplastic, follicular. It causes all. Most commonly papillary. So it causes blood cancer. It causes thyroid cancer. And in others, it causes multiple cancers like skin, breast, ovary, uterus, lung, myeloma. Maximum chances sensitivity of IR radiation is in G2 phase of the cell cycle. G1 as G2M. So G2 is highly sensitive to ionizing radiation. So I hope you all got it. So tell me, rather than reading, we will fill it. So tell me, we have completed. So tell me UV and tell me IR. You tell me UV and IR. Tell me three things about them. You have to tell me the source of both of them. You have to tell me the mechanism of cancer. How does they cause cancer of both of them, and enumerate the cancer. Which cancer does they cause? So tell me the source. The source is very easy. UV light is present in sunlight. And with sunlight, you have to tell me it's UVB which causes cancer, not A and C. B for bad. IR is present in X-ray, alpha ray, beta ray, and gamma ray. Compare them. Now tell me the mechanism of both of them. Rather than telling the mechanism, draw the cell. Draw the cell, draw the nucleus, draw the DNA. Draw the cell, draw the nucleus, draw the double-stranded DNA. Now tell me what does happen here. So here the UV light is falling on the cell. And here IR is falling on the cell. So what does it happen? How does they causes the mutation? So UV light causes pyrimidine dimer formation, because of which mutation occurs. And IR dislodge the water and form the free radical, and the free radical will cause the mutation. So here the main thing is pyrimidine dimer formation, and here free radical formation that you have to learn. Now tell me the cancers. Can you enumerate the cancers, please? Which cancers it causes? Yes. So it causes only one cancer, skin cancer. There are 3 types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. Most common basal cell carcinoma. It causes all leukemias, that is blood cancer, all leukemias except CLL. CLL is not caused. And all thyroid cancer and others. In others, there is a big list. So that's all about it. We are done with physical carcinogenesis. So we are done with radiation induced or physical carcinogenesis is done. You can read the references. You can see the source. You can see the cancers. You see the mechanism. Okay, we are done. Now coming on the chemical carcinogenesis. Physical, you get a short question, either on UV or IR, or sometimes you can get long also. But on chemical, you usually get a long question in your university exam. So chemical leads to cancer. Here there is a chemical that leads to a particular cancer. Let's say the best example I can quote, smoking leads to lung cancer. I guess everyone know smoking leads to lung cancer. So what does the smoke contain? Smoke contain a chemical. The name of that chemical is tar. Smoke contain tar. So tar leads to lung cancer. So smoke contains tar, and tar is a chemical that leads to lung cancer. Okay. So this is the example you can consider. In the similar way, there are many chemicals which leads to particular cancer. Let's say one more example, vinyl chloride. It's a chemical that leads to angiosarcoma of liver. Angiosarcoma of liver. In the same way, there are many other examples. We can say benzene. Benzene leads to bladder cancer. So there are many chemicals which lead to particular cancer. Okay. So how does a chemical causes cancer? So there are 3 stages. Whatever is the chemical, it leads to a particular cancer in the target organ. If I say tar, it leads to cancer in the lung. It leads to lung cancer. If I say benzene, it will lead to cancer in the bladder. If I say vinyl chloride, it will lead to the cancer in the liver. So this is the target organ. This is the target organ. So different chemicals have different target organ. Got my point? So when a chemical causes a cancer, there are 3 stages. You have to understand all 3 stages one by one. First of all, there is initiation, then promotion, then progression. In the initiation itself, there are 4 stages. So I will let you know with the help of a diagram. We will see the same diagram. Now, same example. Tar leads to lung cancer. The tar present in the smoke leads to lung cancer. Let's take this example and understand the steps. For example, someone is smoking. So the tar is going inside. Okay, now this is the 3 steps I will explain you here. So let's start with initiation. What are the 4 steps in the initiation? See the 4 steps in the initiation. Let me explain you with the diagram. For example, this is the liver. You can see this is the liver of a human being. Inside the liver, this is the liver. All human beings have liver. Inside the liver, this is the cell of the liver which is known as hepatocyte. So in the liver, we have hepatocytes. Inside the hepatocytes of the liver, we have endoplasmic reticulum. Inside this endoplasmic reticulum, there is an enzyme which is known as cytochrome P450. Okay, so we have liver, we have hepatocytes in the liver. Inside the hepatocytes, we have endoplasmic reticulum, inside which we have cytochrome P450 enzyme. This enzyme. Now, someone is smoking. I don't smoke, but imagine someone is smoking. So if someone is smoking, the tar present in the smoke will go in the blood. The chemical is present in the blood. So this chemical is inactive. So first this chemical go in the liver via blood. So this is the chemical present in the blood. It can be any chemical. It can be tar, it can be vinyl chloride, it can be benzene, it can be aromatic amines, it can be any chemical. So this chemical first go to the liver. In the liver, the cytochrome P450 will convert this chemical from inactive to active. So first step is metabolic activation. It happens in liver. It happens in the hepatocytes of the liver. It is done by cytochrome P450. So cytochrome P450 enzyme convert the inactive chemical to active. This step is known as metabolic activation, the first step in initiation. So whatever chemical is present in the blood, first it goes to the liver, get converted to active form. So inactive, can you see the red is converted to green, if you can appreciate. So red is inactive version, it converted to green, it comes back to the blood. And via blood, then it will go to its target organ. The target organ can be different. If you say it's tar, so the target organ is lung. If you say it's benzene, the target organ is bladder. So target organ can be different. After becoming active, can you see this become active? Now it will go to its target organ. It will enter in the cytoplasm of the target organ. In the cytoplasm of the target organ cell, in the cytoplasm of the target organ cell, it will lose 1 electron and become electron deficient. It is known as electrophile. So it will have a positive charge on that. For example, sodium lose 1 electron, it is sodium 1 positive. Potassium lose 1 electron, it is potassium 1 positive. Calcium lose 2 electron, it is calcium 2 positive. I guess you know that in chemistry. So whosoever loses the electron, it will become positively charged and it is known as electrophile. It is known as electrophile. So second step is electrophile formation. The first step is metabolic activation that takes place in the liver. So the chemical first come in the liver and by cytochrome P450 enzyme, it get converted into active form. The inactive chemical get converted to active. Okay. Now the active form will go in the target cell. In the cytoplasm of the target cell, it will lose 1 electron. It will lose 1 electron and form the electrophile. It's electrophile formation. It's electrophile formation. Now the DNA is highly positively charged. And the DNA is highly negatively charged. I'm sorry, it is negatively charged. And this particle, this chemical is positively charged because it loses the electrons. So they attract each other. The negative charge attract the positive charge like the magnets. You got my point? So this one is positive charge and DNA is negative charge. They attract with each other. Because they attract with each other, the chemical hit the DNA. So third step is hitting. And because of this hitting, the DNA get mutated. So third step is mutation. Mutated cell is formed. Because of this hit, the positive charge and negative charge attract each other and they hit each other. Because they hit each other, the DNA get mutated. The third step is mutation. So first, metabolic activation takes place in the liver always, in which inactive chemical get converted to active chemical by cytochrome P450. Okay. The second step is electrophile formation, which takes place in the target cell cytoplasm, in which the chemical loses the electron and become positively charged. The third step is hitting, which takes place in the nucleus of the target cell. The electrophile formation was in the cytoplasm of the target cell. Here it is taking place in the nucleus of the target cell, where the chemical hits the DNA because the chemical is positively charged and DNA is negatively charged. And it will become a mutated cell. Now, this is the mutated cell. Now, mutated cell will divide it once. Once it will divide, the mutation become fixed. Now, mutation is there, so P53 can come and fix it. It is a DNA repair gene. But once the cell is divided, nobody is going to fix it. Okay. Once it is divided, it is known as initiated cell. Initiated cell is the mutated cell in which at least one division takes place. So that is the fourth step. So the initiated cell is formed. So there are four steps. What are the four steps in initiation? First, metabolic activation, then electrophile formation, then mutation, and then initiated cell formation. You can see all four here. First, metabolic activation takes place in the liver, in which inactive chemical convert into active. The second, electrophile formation, which takes place in the cytoplasm of the target cell, in which the chemical loses the electron, become electron deficient or positively charged. The third, it will hit the nucleus and do the mutation. The third step is mutation. And then the mutated cell will divide once and fix the mutation, and it will form an initiated cell. So metabolic activation, electrophile formation, mutation, and initiated cell formation. The four steps in the initiation. The same you can see it here. Okay. So first, the metabolic activation takes place in the liver. Then electrophile formation takes place in the target cell. Then mutation takes place, and then the mutation become divided. I mean, one cell division takes place, it converted into initiated cell. These are the four steps in initiation. After initiation, we have to see the promotion. The initiation is over. The second is the promotion. In the initiation, we have four steps. Now, initiated cell is already formed. You see, you understand. This is a normal cell, the target cell. This is a target cell. For example, TAR leads to lung cancer, so it is a lung cell. It is normal lung cell. It don't have any mutation. Now, this is exposed to the chemical. The chemical is the TAR. Okay. Now, because of the four steps, number one, the chemical undergo metabolic activation in the liver. Then it will come and form the electrophile. And then it will hit the nucleus, do the mutation. And then the mutation become fixed and it will form the initiated cell. Okay, initiated cell. Now let me draw the cell again. This is the cell. This is the lung cell. Again the target cell. But now this is mutated and the mutation is fixed. So I must say it is the initiated cell. So this already happened. The initiation already happened. So this was the normal cell and normal target cell, normal lung cell or target cell. This one is mutated or initiated cell, in which these four steps already occurred. Okay, now I have to proliferate it. If we have to produce the cancer, the mutated cell should undergo proliferation and form multiple mutated cells. So for this, another chemical is required. The another chemical is known as promoter. This chemical was initiator, and this chemical is known as promoter. So first we require an initiator. What does initiator do? Initiator causes the mutation. What does promoter do? Promoter do not cause the mutation. Promoter causes the proliferation of the mutated cell. Please mind my words very carefully. What I am saying, what the initiator do? Initiator and promoter both are chemicals. So the sequence is, first we require initiator, then we require promoter. If the combination is present, then only cancer will occur. If one of them is present, cancer will not occur. So first initiator will lead to mutation. So only mutation cannot lead to cancer. We have to proliferate the mutated cell. So for proliferation of the mutated cell, we require promoter. So initiator followed by promoter, that should be the sequence. Sometimes, so it means we require two chemicals for producing cancer. So sometimes the one chemical only, like TAR, it is initiator also, promoter also. So first it will do the function of initiator, it will do the mutation. And once the mutated cell is formed, it will proliferate it and do the function of promoter. So sometimes one chemical is doing both the function and sometimes two different chemicals are required. So what is a promoter? Promoter is the chemical that do not cause mutation. No, it's not mutagenic. What does it do? It causes the proliferation of already mutated cells. So we require a promoter. Now have a look. We have 5 groups of patient. Can you see? Group 1, 2, 3, 4, 5. What we are doing? If we are, the cross is the initiator and the triangle is promoter. If we are giving only initiator, no cancer. Only initiator cannot produce. If the mutation will be there, but the mutated cell cannot proliferate. If you are giving only promoter, there is no cancer. There is no cancer. If you are giving first promoter followed by initiator, no. This is not the correct sequence. So first we have to give initiator followed by promoter. Initiator followed by promoter. Now they can be continuous or there can be a gap in between. In both these scenarios, tumor can happen. So if you want to produce a tumor in a patient via chemical, so initiator should be followed by promoter. That is the sequence. Promoter should not be followed by initiator. So the summary is only initiator cannot produce cancer. Only promoter cannot produce cancer. Okay. The promoter followed by initiator cannot produce cancer. But the initiator followed by promoter either in continuation or with gap can produce cancer. So here no cancer, no cancer, no cancer. Here only cancer can occur. So this is the summary. With this beautiful diagram, we have summarized it. Initiator should be followed by promoter. Then only cancer will occur. So second step is done. First initiation is done, then promotion is done. Finally progression. The third and the last step is the progression. So you know till now what has happened. So this is the normal cell, normal target cell. The first thing, it should be mutated and initiated. So first is initiator. We require a chemical here which is known as initiator that will lead to mutation here. And then we require another chemical. The name of the another chemical is promoter. We require promoter. What does the promoter will do? It will cause the proliferation of already mutated cell. And finally, till now the cancer is there. For example, there is a person who smoking contains tar. So tar is first acting as the initiator. So in the lung cells, mutation is there. Now tar is acting as a promoter. So they are proliferating also. Okay, but the patient don't have cough. So when the phenotypic expression is there, phenotypic expression, the phenotypic expression means when the symptoms, patient have cough, dyspnea, then it is known as progression. So only mere presence of the mass in the target organ do not produce cancer. It should be phenotypically expressed. So phenotypic expression is the progression. So what are the 3 steps? Initiation, promotion, progression. Can you define the 3? So this is the complete 3 steps of chemical carcinogenesis. What are the 3 steps? First, we require initiation, then we require promotion, then we require progression. Can you please enumerate? Can you please explain what is initiation? In initiation, the mutation occurs. In promotion, the proliferation of the mutated cell occurs. And in progression, the phenotypic expression of the cancer occurs. So this is the definition of the 3. I hope you all got it. So this is the complete 3 steps. The 3 steps of chemical carcinogenesis. Can you tell me 3 steps of chemical carcinogenesis? Can you summarize it quickly? The 3 steps of chemical carcinogenesis, 1, 2, and 3. The 3 steps of chemical carcinogenesis. Can you please summarize it quickly? Yes. The 3 steps are initiation, then promotion, then progression. Initiation, promotion, progression. Initiation have 4 steps in that. 1, 2, 3, 4. Initiation has 4 steps in that. What are the 4 steps in initiation? Can you please tell me the 4 steps in the initiation? The first step is metabolic activation. So first the chemical goes in the liver and get activated. Then it will go in the target organ and form the electrophile. It will lose the electron and form the electrophile. That is positively charged ion. Then it will hit the nucleus and produce mutation. And then it will divide it once to fix the mutation, that is initiated cell is formed. This is known as initiated cell. Now finally, we require another chemical which will cause the proliferation of the mutated cell, the initiated cell. For that we require promoter, the another chemical. And finally, we require the phenotypic expression of the cancer, that is progression. So that is the 3 steps, that is the summary. You have to draw the diagram and explain in detail. Now tell me a test. Tell me a test that proves it. So there is a name of a test that is known as Ames test. Ames test is a test for proving chemical carcinogenicity. So with this test, I will prove that chemical carcinogenesis actually happens. So what we are doing, we are taking a test tube. In the test tube, we are taking a bacteria. The name of this bacteria is Salmonella typhimurium. It's not Salmonella typhi. It's not the bacteria which causes typhoid. It's known as Salmonella typhimurium. It's a bacteria. Now there is a property of this bacteria. It requires histidine for its growth. Histidine, without which it cannot grow. So you have to provide histidine in the medium, then only it can grow. Okay, otherwise it cannot grow. I mean, it is the mutated version. So you are taking a bacteria in the test tube. The name of the bacteria is Salmonella typhimurium. It is mutated version. You are taking a mutated bacteria. What is the mutation in that? Normally it can synthesize histidine, but here the mutated one cannot synthesize histidine. So if you want to grow it, you have to grow the histidine from outside. So you are taking a mutated bacteria. You will say, ma'am, from where we will bring? It's available commercially. So this mutated version of Salmonella typhimurium is available commercially. You have to take it in a test tube. Okay. Now take a jar. In this jar, take few drops of the bacterial suspension, and mix it with the chemical you want to test. Mix the two. What does the chemical do? You say, ma'am, chemical do the mutation, but this is already mutated bacteria. If it was an unmutated bacteria, chemical will do the mutation. But if it is already a mutated bacteria, chemical will reverse the mutation. So if it was the normal, the bacteria have the normal DNA, chemical cause mutation. Chemical will cause the mutation. If you are exposing it with the chemical, it will cause the mutation. But here it is already mutated bacteria. So basically the chemical will reverse the mutation. The chemical will reverse the mutation and it will become normal again because of exposing of the chemical. So you are taking a mutated bacteria and exposing it with the chemical, the mutation will reverse. How you will check it? Try to grow it in histidine-free media. If it can grow and form the colonies, that means the mutation is reversed. So this is a test which is proving that there is chemical carcinogenicity. The name of the test is AMEES test. I hope you got it. Now please learn few examples if you are preparing for your second Prof university exam from here. Now this is a list of chemical and this is a list of particular cancer it causes. For example, alkylating agents causes AML. Androgens causes prostate cancer. Aromatic amines, aniline causes bladder cancer. Arsenic causes lung cancer. Asbestos also causes mesothelioma. Estrogen causes endometrial cancer. So you have to learn the chemical with the corresponding cancer. Learn at least 10 examples. Learn at least 10. So you can retain at least 5 in your exam. If you learn only 5 now, you will retain only 2 in your exam. So please learn the examples. Okay, I have told you, you can write down the tar. Tar lead to lung cancer. Likewise. Vinyl chloride is important, and if you're preparing for competitive exam, these all are important. One-liner questions come in the form of the MCQs. So we are done with chemical carcinogenesis. We are done with physical carcinogenesis, in which I have discussed the radiations, UV and IR. We have discussed the chemical carcinogenesis, in which I have discussed the steps, the 3 steps of chemical carcinogenesis: initiation, promotion, progression. And finally, I'm coming on last, biological carcinogenesis. So let's start biological carcinogenesis finally here. In the biological carcinogenesis, basically we are having certain viruses that causes cancer, certain bacteria which causes cancer, and certain parasites which causes cancer. So first of all, I want you to learn this list. These are the list of biological agents which causes cancer. These are known as oncogenic organisms. Carcinogenic organisms are also known as oncogenic. Oncogenic or carcinogenic organisms. They leads to cancer. So there are certain viruses. You have to learn the name of these viruses. These are 7 viruses. Please learn them. Human papilloma virus, it leads to genital cancer. In females, it leads to cervix cancer. In male, it leads to penis cancer. Epstein-Barr virus leads to nasopharyngeal carcinoma and Burkitt lymphoma. Hepatitis B virus and hepatitis C virus, they lead to liver cancer, hepatocellular carcinoma. HIV leads to Kaposi sarcoma and non-Hodgkin's lymphoma. HTLV leads to human adult T-cell leukemia. And HHV8 again leads to Kaposi sarcoma. So you have to learn the name of the viruses. They leads to cancer in human. Learn the particular cancer also. Only one bacteria leads to cancer. The name of that bacteria is H. pylori. It leads to stomach cancer. The cancers in the stomach, the 2 cancers in the stomach, I will enumerate it. And there are 4 parasites which leads to cancer. What are the 4 parasites? Schistosomiasis, Clonorchis sinensis, Opisthorchis viverans, and Fasciola hepaticula. So first of all, I want you to learn the name of the oncogenic organisms. Oncogenic or carcinogenic organisms. So enumerate the viruses, enumerate the bacteria, and enumerate the parasite. So if you are getting a question on overall biological carcinogenesis, you have to write down. And sometimes you can get question only on viruses, only on bacteria, or only on parasites. So you have to write that particular portion. So please, before start writing, understand your question very carefully. Got my point? So here viruses, you have to enumerate the 4 viruses. What are these? Human papilloma virus, HIV, HTLV, okay, hepatitis B virus, hepatitis C virus, Epstein-Barr virus. So these are 6-7 viruses. Bacteria is only one, H. pylori. That's it. And parasites are 4. Schistosomiasis, Fasciola hepatica, Opisthochus sinensis, and one more is there, Clonorchus sinensis. So that you have to learn. Okay. Now among the viruses, I will give you detail of 2. Which 2? Among them, 2 of them are RNA and remaining all are DNA. So these are the total viruses. You have to divide them according to DNA viruses and RNA viruses. You may have seen the viruses are of 2 types. In the microbiology, you may have read it. The 2 types of the viruses, DNA and RNA. Got it? So you have to divide all the 7 viruses. Which of them are DNA? Which of them are RNA? So you have to divide all 7. So 4 of them are DNA. HBV, HHV8, HPV and EBV. 3 of them are RNA. You can add HIV also. HIV, HCV and HTLV. These are the RNA viruses. So you can learn the classification like that. Now among them, I will give you the detail of 2. I will give you the detail of HPV and EBV. Sometimes you get a short question. How does HPV leads to cancer? Tell me the mechanism. How does EBV leads to cancer? Tell me the mechanism. So we will see the details of the 2. So let's start with HPV, human papilloma virus. How does it causes cancer? Listen, this is a genital cell or skin cell. This is a human cell. This is a cell of human. Okay, maybe the genital cell or the skin cell of the human. Maybe the genital cell, either the cervix cell in the female or the penis cell in the male or the skin cell in both of them. Okay, any of them. So here it is exposed to human papilloma virus, HPV virus. Once the HPV virus enters in the cell, it will form 2 proteins, E6 and E7. These are the 2 proteins formed by the cell. Now this is the DNA. This is the human DNA. E6 and E7 causes one gene mutation. E6 and E7 both will go in the nucleus. E6 will cause the mutation of P53 gene and E7 causes the mutation of RB, retinoblastoma gene. You have to learn particularly. So how to learn? RB, retinoblastoma. RB stands for rainbow also. Retinoblastoma or rainbow. Rainbow have 7 colors. 7 colors, I know. You know that, I mean. Okay, so E7, the 7 colors is causing the retinoblastoma mutation and E6 is causing the mutation of P53. This is how you have to learn and it will lead to cancer. It will lead to cancer. So this is the mechanism. The same is shown to you. So HPV causes 2 proteins, E6 and E7. Please learn it. E6 causes mutation of P53 and E7 causes mutation of retinoblastoma that leads to cancer. So the cell will become immortal and uncontrolled mitosis and that leads to cancer. How many types of HPV are there? There are more than 100 types of HPV. Some of them causes benign cancer and some of them causes malignant cancer. Okay, the one which causes benign cancer are known as low risk HPV. They cause benign cancer. They cause cancer but benign. Some of them are high risk. High risk HPV means they cause malignant cancer. So from the 100 types or more than 100 types, which of them are low risk and which of them are high risk? 6 and 11 always causes benign. 6 and 11 type. Serotype 6 and serotype 11 always causes benign. They are low risk HPV. And 16, 18, 31, 33 and 45. These 5 are the most common which always causes malignancy. Most common in this sequence only. Most common is 16 followed by 18, then 31, 33, 45. These are high risk. So learn the numbers. 6 and 11 are low risk HPV. They causes benign cancer, that is warts in human. And 16, 18, 31, 33, 45, these are high risk HPV because they cause malignant cancers in males and females, the genital cancer. I hope you got it. So this is the HPV virus you can see. This is the HPV virus which enters in human cell and after that it forms 2 proteins E6 and E7. E6 mutate P53 gene and E7 mutate retinoblastoma gene that leads to cancer. It leads to 2 types of cancer, benign and malignant. The benign cancer are known as warts and the malignant cancers are genital cancers in male and female. So the benign cancer is caused by low risk HPV and malignant one are caused by high risk HPV. The low risk HPV are 6 and 11 and high risk HPV is 16, 18, 31, 33 and 45. So you have to learn all this. Okay. Now coming on the next virus is, you can see here the next virus is Epstein-Barr virus. Now tell me the mechanism, how does it leads to cancer? The Epstein-Barr virus, how does it leads? So which cancers it causes? Mostly it causes Burkitt lymphoma, nasopharyngeal carcinoma, T-cell lymphoma and some Hodgkin and non-Hodgkin's lymphoma rarely. But most commonly it leads to Burkitt lymphoma and nasopharyngeal carcinoma. How does it causes? So let me draw a human cell again. So this is a human cell. This is the nucleus of the human cell. This is the DNA of the human cell. Now EBV is entering. Epstein-Barr virus. By the way, Epstein-Barr virus is also known as kissing virus, because it is present in the saliva of human and it spread from one person to another via kissing. So that's why it is known as kissing virus. So just suppose some individual have acquired this virus, some person because of kissing. So virus is present in the saliva of that person in the mouth. So from there, from the saliva, it will go to the nasopharynx. In the nasopharynx, this virus will bind with the B lymphocytes present in the tonsils. In the nasopharynx, we have tonsils. In the tonsils, we have B lymphocytes. So on the B lymphocyte, the Epstein-Barr virus will come and combine with the tonsils, the B lymphocytes of the tonsil. So here this is Epstein-Barr virus. On the B lymphocyte, we have a receptor which is known as CD21. So this Epstein-Barr virus will combine with CD21 and enter inside the cell. Once this Epstein-Barr virus enter inside the cell, it will form a protein. The name of the protein is LMP1. What was the protein formed in HPV? HPV was forming two proteins, E6 and E7. Here it is forming only one protein, that is LMP1. This LMP1 will go inside and do multiple mutations, because of which the cell will become immortal. The cell will become immortal, and in future it can acquire certain mutation, and that will lead to nasopharyngeal carcinoma, Burkitt carcinoma likewise. So this is the mechanism. I hope you got it. So this is the Epstein-Barr virus. It will go to CD21 receptor of the B lymphocyte present in the nasopharynx. Because of the saliva, from the saliva it is going, and it is bind with the CD4 it will bind with the B lymphocyte. It will enter inside the B lymphocyte and form LMP1 protein. That will cause the mutation, because of which it will become immortal. And in future, it can acquire 8-14 translocation that will lead to Burkitt lymphoma. I hope you got it. So you have to enumerate all 7 viruses, and you have to tell the mechanism of 2 of them, HPV and EBV, in detail. I cannot tell you the mechanism of all because they are not important at your level in your syllabus. The 2 are ultra important, HPV and EBV. You have to describe the detail. So enumerate all 7 viruses and describe the detail of the 2. That is virus-induced cancer. Enumerate the 7 and give the details of the 2. Okay, how does they cause this? Draw the flowchart of HPV, enumerate the cancer. Draw the flowchart of EBV, enumerate the cancer. Coming on bacteria. Only one bacteria leads to cancer. The name of the bacteria, carcinogenic bacteria, is H. pylori. Helicobacter pylori. Only one bacteria. It causes cancer in only one organ. Only one organ, stomach. You can see the stomach. It causes cancer only in stomach. It causes 2 cancers in the stomach. It causes gastric adenocarcinoma and gastric lymphoma. The gastric lymphoma is known as maltoma. So basically, it leads to gastric lymphoma or maltoma and gastric adenocarcinoma. Both of them are in stomach. And only one bacteria. There are many bacteria, hundreds of bacteria, but only one of them causes cancer. We have discovered only one yet, which causes cancer. So this is the H. pylori. It causes 2 gastric cancer, gastric adenocarcinoma and gastric maltoma, lymphoma or maltoma. So please learn that. And finally, we have the parasites. We have the parasites. So the parasite, there are 4 parasites which lead to cancer. Learn their name. That's it. We don't have to understand the mechanism. What are the 4 parasites? Schistosomiasis, which leads to bladder cancer. The squamous cell carcinoma of the bladder, not transitional cell carcinoma. Mind it for your MCQs. So it leads to squamous cell carcinoma of the bladder. Clonorchis sinensis, Ophisthochus viverans, and Fasciola hepatica. Clonorchis sinensis leads to the remaining 3. These all leads to bile duct carcinoma or cholangiocarcinoma. So cholangiocarcinoma here also, here also, here also. But Clonorchis sinensis along with cholangiocarcinoma, it leads to liver cancer also. So please enumerate the parasites along with the cancers that is causing. So I hope we are done. So we have done the big topic, that is carcinogenesis, but it was worth listening because you are going to get a long question on any of them, either on the physical carcinogenesis or chemical carcinogenesis or biological carcinogenesis. So in the physical, I taught you 2 things, UV and IR. I taught you the source of each of them, the mechanism of each of them, and the cancers they are causing. Enumerate them, make a comparative table. Okay, in the chemical, I taught you the 3 steps. How does initiation occur, promotion occur, progression occur. In the initiation itself, I taught you the 4 steps by taking an example. And I taught you a test for carcinogenicity, that is Ames test. In the biological, first enumerate the 7 viruses. Tell me the mechanism of the 2, HPV and EBV. Don't forget the proteins in the HPV, E6 and E7. And don't forget the protein in EBV, that is LMP1 protein. Only one bacteria causes cancer, that is H. pylori. And there are 4 parasites which causes cancer. So first enumerate all and tell the mechanism of viruses only. Okay, that's all about it. I hope you learned it and you enjoyed the session. Yes, don't forget to have a look on the long questions, especially for this section. Short question, very short question and MCQ. It is given in the notes as well as question bank. So have a look. Don't forget it. Have a look right now, just after watching the session, so that you will become confident that whatever question coming from this section in your university exams, you are prepared. Okay. Hello everyone. In this session, we are going to discuss the clinical features of neoplasia. So you usually get a short question on one of the 2 important clinical features of neoplasia, that is tumor lysis syndrome or paraneoplastic syndrome. So please concentrate on these two clinical features more specifically, but overall, sometimes you can get overall all the clinical features, then you have to write down all, but these two are ultra important: tumor lysis syndrome and paraneoplastic syndrome. So let's start the clinical features of neoplasia. So you can see here, we are starting a topic that is clinical features of neoplasia. So you can see here it is. So I will be discussing the clinical features, enumerate the clinical features of neoplasia under two types: local effects and systemic effects. So there are 4 local effects of the neoplasia and 4 systemic effects of the neoplasia. The 4 local effects are compression, obstruction, tissue destruction, and infarction, ulceration, hemorrhage. And 4 systemic effects are cachexia, fever, and the last 2 are ultra important, that I am saying that tumor lysis syndrome and paraneoplastic syndrome. So please concentrate on these 2 more specifically. You get very frequently questions on these 2 separately also. So let's start one by one. So you can, first of all, whatever question you are getting on the clinical feature, you are getting a separate question on tumor lysis syndrome, or you are getting a separate question on paraneoplastic syndrome, or any of them. Sometimes you get a very short note on cachexia. So you are getting a question on any of them. First of all, enumerate all of them. So first of all, enumerate all the clinical features of neoplasia in your university exam. So please enumerate them under 2 headings. So in cancers or neoplasia, 2 type of clinical features occur: local effects and systemic effects. There are 4 local effects and 4 systemic effects. So total 8 effects of the neoplasia. We will discuss all 8 one by one. Let's start with the first 4 local effects. So I guess you understand what do you mean by the local effects of the neoplasia or cancer, and what do you mean by the systemic effects of neoplasia or cancer. So in local effects, we are discussing first is compression. What do you mean by compression? Some benign tumors, they are compressing, they are presenting at the critical location, and due to the compression, they produce the symptoms. The symptoms are due to compression of certain structure. The best example I can quote here is benign prostatic hyperplasia, BPH. You can see it here. You know what is BPH? Okay, you know prostate is a gland which is present only in males, not in females. So in males, this is the urinary bladder, and this is the urethra. This is the urinary bladder and the urethra. You can see this is urethra. So at the neck, at the commencement of the urinary bladder, you can see there is a gland. This is the prostate gland. It is circular in nature. It is circular, and in the circle there is a hole from which the urethra is passing. You can see there is a hole from which urethra is passing, and this is the prostate gland. This is normal. Now we know whenever there is a critical amount of urine get accumulated in the bladder, the person have a sensation of micturition. The person uses the washroom and passes the urine. The act of passing the urine is known as micturition. Micturition is passing the urine. So this is normal. This is a healthy male. Now sometime in the prostate gland, there is a cancer, the benign cancer of the prostate gland, which is known as benign prostatic hyperplasia, in which the gland enlarge in size. It is a benign cancer. It is benign prostatic hyperplasia, BPH, in which the gland is enlarged in size. So gland is enlarged in size. So what it is doing, it is compressing the urethra. You can see in the center of the gland, there is a hole from which the urethra is passing. So this is the gland. It is circular in nature. In the center, there is a hole from which the urethra is passing normally. So here the gland is, which is enlarged in size, it is compressing the urethra. So urethra will become like this. You can see the urethra get compressed. It will get compressed. The lumen inside the urethra will get compressed. It is getting highly compressed like this. It will become highly compressed like this. You can see the urethra become highly compressed like this. So this person have a sensation of passing the urine. But when the person start micturating, the urine will come drop by drop because the urethra is compressed. So the person is having a sensation, the bladder is full. So as soon as normal healthy human start micturating, if the bladder is full, the urine comes in a flow, in a high flow. But here, although the bladder is full, the person requires many minutes, maybe 5 minutes, 10 minutes, sometimes 15 minutes to empty the bladder, not within few minutes or few seconds. So because the urine is coming drop by drop, the dribbling of the urine. So this is the most common complaint of such patient, that is dribbling of the urine. So they feel whenever the bladder is full and they start micturating, the urine come drop by drop. This is benign prostatic hyperplasia, and you can see it is due to the compression of the urethra. So this is one of the example we have seen of compression. There can be another examples also, like pituitary adenoma in the brain. Okay, here you can see the prostate gland, benign prostatic hyperplasia, it is compressing the urethra. You hardly see any urethral lumen at the center. The urethra is completely compressed. So this person is having the urine coming out dribbling, drop by drop. So that is compression. The second is mechanical obstruction. Obstruction occurs in illuminated organ. The best example is the intestine, human intestine. Sometimes there is cancer in the intestine. Can you see the cancer in the intestine, the small intestine, the large intestine, the colon, any of the intestinal portion can have cancer, and that is causing the obstruction, and that will produce the symptoms. The obstruction can have severe pain, and sometimes due to the obstruction, perforation can also occur. So that is mechanical obstruction. So sometimes symptoms are due to compression, and sometimes the symptoms are due to obstruction. The best example is the intestine. The third is sometimes the symptoms are due to destruction. So malignant cells, not benign, the malignant tumors, they invade inside the tissue, they infiltrate inside the tissue and destroy them in whatever tissue they are. So for example, there is a breast cancer. So there is a breast cancer. It's the malignant cancer we are talking about. So the malignant cancer in the breast, it will infiltrate in the surrounding tissue, and it will go in the pectoralis muscle, and it will involve the ribs also. Sometimes it is destroy the ribs. It will come outside and destroy the nipple also, destroy the skin also. So it is destruction, local destruction. And finally, the ulceration, hemorrhage, and infarction can be there. So there are four type of symptoms because of the local effects. What are they? Compression, obstruction, tissue destruction, and ulceration. So that is due to local effects. So we have seen the examples and local effects. Now coming on the systemic effects of the cancer, systemic effects of the neoplasia. So there are four systemic effects. We will see them one by one. First, we will see cancer cachexia. Then we will see fever. Then we will see tumor lysis syndrome and paraneoplastic syndrome. These two are ultra important. So let's start with cachexia. What is cachexia? In cancer, the person loses weight too much, abundant weight loss, and person is too thin. The cancer patients, it is known as cachexia. What is cachexia? Now, why it is happening? The person is losing weight, abundant weight loss, the muscle atrophy. You can see all the muscles are atrophied. Muscle atrophy is there. Quality of life is reduced. QOL is quality of life. So you can see here the quality of life is reduced. The quality of life and anemia. The person is anemic. So these are the four properties of cachexia. In cachexia, the person is losing the weight. You can see the person is having muscle atrophy, weight loss, muscle atrophy, the person is having anemia and reduced quality of life. Now, why does it happen? Why does? Now, in cancer, patients don't have hunger. They don't feel hungry too much. They have loss of appetite. That is known as anorexia. So, in cancer, the loss of appetite is there, maybe due to chemotherapy or other effects, or due to cancer itself. The patient don't have hungry feeling. They have loss of appetite. So, they are not eating anything. That's why they can have cachexia. Number one reason. The cancer cells secrete pro-inflammatory cytokines and anabolic hormones. The pro-inflammatory cytokines are many interleukins, interleukin 1, 6, tumor necrotic factor, tumor growth factor, and anabolic hormones like insulin. So what does they do? They do proteolysis, lipolysis. So proteolysis, all the protein is destroyed. Lipolysis, all the lipid is destroyed. That also leads to anorexia. And the anabolic hormones also causes the same, that reduces the protein synthesis, reduce the myogenesis, reduce the adipogenesis, and that leads to cachexia. So there are three causes of cachexia in cancer patient. For example, there is a cancer patient, so three things happens. Number one, the patient don't feel hungry. Patient have loss of appetite. That is known as anorexia. So due to anorexia, patient is not eating anything. That's why the patient is having weight loss. So first reason for cachexia is anorexia only. Number one, that's why the patient is having cachexia. Okay, cachexia is weight loss. That's why the patient is having weight loss, number one. Number two, the cancer cells secrete pro-inflammatory cytokines. I told you the example, interleukin 1, interleukin 7, 6, tumor necrotic factor. And all of them, what does they cause? They increases the lipolysis, proteolysis. So protein is degraded and lipid is degraded. That's why the patient have cachexia. And third thing, cancer cells secrete anabolic hormones. Anabolic hormones means insulin. So it decreases protein synthesis. Protein degradation is high, but synthesis is less. Lipid degradation is high, but synthesis is less. Again, it leads to cachexia. So these are the three causes of cachexia in a cancer patient. And how does you define cachexia? There are four criteria to say cachexia in a cancer patient. There is a cancer patient who is having weight loss. Number one, weight loss. Number two, muscle atrophy. Number three, anemia. And number 4, reduced quality of life. If all these 4 criteria are present, we will, in a cancer patient, we will see the patient is cachexia. The cancer patient is cachexia, and this is the causes of cachexia. The 3 causes of cachexia you must understand. Number 1, loss of appetite, that is anorexia. Patient is not eating, that's why losing the weight. Number 1, the cancer cells secrete pro-inflammatory cytokines, which increases protein degradation and lipid degradation. And number 3, the cancer cells secrete anabolic hormones like insulin, that is reducing the protein synthesis and lipid synthesis. And that's all leading to weight loss, that is cachexia. I hope you got it. So this is the mechanism of the cachexia. So it is a systemic effect. It is one of the systemic. It is not local. It is the systemic. Some of the cancer patients have fever. Not all cancer, but some of the cancer patient can have fever because cancer cells secrete pyrogens. Cancer cells secrete all these pyrogens like interleukin 1, interleukin 6, interleukin 10, TNF alpha, interferon. All these are pyrogens. What does they do? They increase this prostaglandin E2. Prostaglandin E2. Prostaglandin E2 goes in the hypothalamus and reset the temperature regulation, and that will lead to fever. So this is the mechanism of fever in certain cancers, not all. In certain cancers, the tumor cells, the cancer cells in certain cancers secrete the pyrogens that will increase the prostaglandin E2, that will reset the hypothalamus temperature regulation and causes the fever in certain cancer patients. The third one is ultra important. You get very frequently short note on this. So make a 5-star over it. That is tumor lysis syndrome. Let me explain you what is tumor lysis syndrome. There are certain cancers which are rapidly dividing, in which the cancer cells divide like anything. So rapidly dividing cancer cells are there. If the cells is dividing rapidly, they will destroy rapidly. So simple rule. If the cell are dividing rapidly, they will also destroy rapidly. So all the cancers in which the cells are rapidly dividing, the cells are rapidly destroying also. Okay, tell me such cancers, tell me few examples of such cancer. For example, Burkitt lymphoma. The cells are rapidly dividing and rapidly destroying also. ALL, chronic tumors like CLL, and uncommon solid tumors. In all of them, the cells are rapidly dividing as well as rapidly destroying. Since the cells are rapidly destroying, it leads to tumor lysis syndrome. Tumor lysis syndrome occurs only in those cancers in which cells are rapidly destroying. Imagine a cell which got ruptured. Can you see this cell is ruptured? This cell, not only one cell, unlimited cells. I can say hundreds or thousands of cells are ruptured together because this person is having a cancer in which the cancer cells are rapidly dividing. Since they are rapidly dividing, they are rapidly destroying also. Now this is a cancer cell which got ruptured. So what will happen? So millions of cancer cells got ruptured together. Thousands of them got ruptured together. So inside the nucleus, you can see this is the nucleus. When the nucleus get ruptured, so nucleic acid will come. Nucleic acid will convert into uric acid. So such patients have high uric acid hyperuricemia that will lead to renal failure. Hyperuricemia will lead to renal failure. The cytoplasm will, when the cell is ruptured, the cytoplasm contains potassium. So such patient will have hyperkalemia. The potassium will come in the blood. So in the blood, uric acid is high, hyperuricemia. In the blood, potassium is high, hyperkalemia. That will lead to arrhythmia. Such patients can present with arrhythmia. And the cytoplasm also contains phosphate. So such patients have hyperphosphatemia. Now phosphate will come in the blood. In the blood, phosphate will combine with the calcium. So calcium level will fall. So patient have hyperuric acid, hyperpotassium, hyperphosphate, and hypocalcium. These are the 4 properties of tumor lysis syndrome. Tumor lysis syndrome. Tumor lysis syndrome occurs when the cancer cells rupture at a high speed. So such cancers which are highly proliferating, in which the tumor cells are also highly destroyed. So hundreds, thousands, millions of tumor cells, they are destroying together, they are getting ruptured together. When a tumor cell gets ruptured, from the nucleus, uric acid is coming, so hyperuricemia. From the cytoplasm, potassium is coming, so hyperkalemia. From the cytoplasm, phosphate is coming, so hyperphosphatemia. Phosphate will combine with the calcium in the blood, so hypocalcemia. Hyperkalemia, hypocalcemia. So only calcium is less and remaining 3 are high. So that is the deadly combination. The 4 things which happen in tumor lysis syndrome. Tell me the consequences. Hyperuricemia will lead to renal failure. Okay, such patients present with renal failure. Hyperkalemia leads to arrhythmia. Okay, and phosphate is high and calcium is low. That will lead to calcium phosphate imbalance. Calcium phosphate imbalance will occur in the body. So that is the consequences of tumor lysis syndrome. Can you enumerate the 4 things in tumor lysis syndrome? 1, 2, 3, 4. So there is hyperuric acid, hyperuricemia in the blood. There is hyperpotassium, that is hyperkalemia in the blood. There is hyperphosphatemia in the blood, and hypocalcium, hypocalcemia, hyperkalemia and hypocalcemia. Don't forget. And you know the reason of all of them. Why uric acid is high? Because of increased nucleic acid, rapid destruction of the nucleus. This is coming from the cytoplasm. This is also coming from the ruptured cytoplasm. And this is low because it is forming complex with the potassium. And what is the consequences of each of them? You know the consequences also. Hyperuric acid leads to renal failure. Hyperpotassium leads to arrhythmia. And potassium and calcium will lead to imbalance. Calcium phosphate imbalance in the body. So that is the meaning of tumor lysis syndrome. It occurs in rapidly dividing and rapidly destroying tumor cells like Burkitt lymphoma. So hyperuricemia due to increased nucleic acid, and that will lead to renal failure. Hyperkalemia because of intracellular potassium which is coming in the blood, that will lead to arrhythmia. Hyperphosphatemia because of increased phosphate which is present in the cell, in the cytoplasm. And hypocalcemia because the elevated phosphate will form a complex with the calcium. So free calcium will fall. So that is the thing. The same thing is shown to you. Hyperkalemia, hyperuricemia, hyperphosphatemia, but hypocalcemia. So please learn the 4 properties of tumor lysis syndrome. We can draw this flowchart also. So when the tumor cells are destroying very rapidly, the potassium will come out and that will lead to arrhythmia. The nucleic acid will come out, that will lead to uric acid, and that will lead to acute renal failure. The phosphate will come out, that will combine with the calcium, so calcium will fall. So you can draw this flowchart also. And finally, the 4th and the last clinical effect is paraneoplastic syndrome. So I'm teaching you the systemic effects of the cancer. We have already seen cachexia, the causes of cachexia, the mechanism of cachexia. We have seen the fever. I told you the mechanism of fever. Then I told you the mechanism of tumor lysis syndrome. And now I'm telling you paraneoplastic syndrome. What is paraneoplastic syndrome? Do you understand what is paraneoplastic syndrome? The name itself depicts its meaning. What do you mean by neoplasia? Neoplastic, it's cancer. And what is para? Para means near, aspas, near, nearby. So, you know, sometimes a patient is coming to your clinic. For example, there is a patient coming in my clinic. Okay, there is a patient coming in my clinic. Okay, the patient is having lung cancer. The patient is having lung cancer. So patient do not come to me and say, doctor, I'm having lung cancer, treat me. No, it's not like that. So patient tell us the symptoms. Based on the symptoms, we do certain investigation. Based on the investigation, we come on the diagnosis. Patient don't give the diagnosis. We, the doctors, make the diagnosis based on the symptoms given by the patient. Okay, so symptoms are very important. So if the patient is having lung cancer, what symptoms I'm expecting the patient should tell me? The patient should come and say, doctor, I'm having cough, I'm having dyspnea, I'm having blood in the sputum, that is hemoptysis. So, and I'm a smoker. So if the patient is complaining all these, I will have a suspicion that this patient can have lung cancer, and I will ask for the radiological imaging, maybe CT, MRI, chest x-ray. Based on that, I can conclude whether the person is having lung cancer or not having lung cancer or any other benign disorder in the lung. Okay, so the symptoms are important. All the symptoms the patient is saying here are related to the respiratory tract. That's why I will have a differential diagnosis in our mind. Yes or no? So symptoms are important. Now imagine there is a patient, the same patient having lung cancer, coming to my clinic. The patient is not at all complaining of any of these symptoms. Patient is not saying, I don't have any cough, I don't have any dyspnea, I don't have any hemoptysis, bleeding in the sputum. No. So what the patient is having? This patient is having some other symptoms. For example, the patient is having moon faces. The patient is having buffalo hump. The patient is having Cushingoid syndrome symptoms. So, shall I suspect lung cancer? You say, what is the relation? You are saying the patient is having moon faces, buffalo hump. How it is related to the lung cancer? I will not suspect lung cancer. This is paraneoplastic syndrome. I mean, the patient is complaining something else and the problem is something else. You got my point? So sometimes patient don't complain of the primary complaint. Patient don't have symptoms of the primary cancer. Patient have some other symptoms. So being a doctor, we should be aware of such other symptoms. So it is possible that a lung cancer patient can present with Cushingoid syndrome, and that is the earliest finding. Because the cancer in the lung is very small and it is not presenting with the primary complaints. Patient don't have cough for that. Patient don't have dyspnea. Patient don't have hemoptysis because cancer is very small. But this cancer, what does it do? Why other symptoms are produced? So this cancer, this lung cancer is secreting certain hormones in the blood, certain hormones or hormone-like things in the blood, and that is producing some other symptoms which are unrelated to the primary cancer. So that is the meaning of para. Para means nearby. Paraneoplastic syndrome. So patient don't complain of neoplasia. Patient complain of the nearby symptoms of the neoplasia. Patient don't complain of the main neoplastic symptoms. Patient complains of the nearby symptoms which are not related to neoplasia, some other symptoms. That is paraneoplastic syndrome. So what is how you will define paraneoplastic syndrome? It's a group of condition in which the patient with certain advanced cancer, they present with symptoms which are neither explained directly or neither explained by the metastasis of the tumor. So some other symptoms are there. So 10 to 15% of the patient develop certain symptoms of the cancer patient. Not all cancer patients develop with these symptoms. Sometimes it is the earliest manifestation of a latent cancer. The cancer is hidden and patient is presenting with these symptoms. Got my point? So that is, so you should know the definition of paraneoplastic syndrome and the list. So there are certain endocrine syndromes, there are certain neuromuscular syndromes, osseous joint soft tissue related syndromes, hematological syndromes and gastrointestinal syndromes, renal syndrome, cutaneous syndrome and amyloidosis. So if you are preparing for your second Prof university exams of pathology, you should learn few examples in each category. Okay, the most important among them is endocrine. For example, patient with lung cancer, they don't present with primary lung cancer symptoms. They don't present with cough, dyspnea. No. They're presenting with hypercalcemia. They have increased calcium in their blood and the symptoms are due to increased calcium. You will say, ma'am, why they have increased calcium in the blood? Because the lung cancers secrete parathormone in the blood and parathormone is increasing the calcium. So patient is coming to you with increased calcium symptom. Patient is not coming to you with cough, dyspnea and hemoptysis. Primary cancer symptoms are absent. Some other symptoms are present due to paraneoplastic syndrome. In the same way, sometimes the lung cancer patient presents with Cushing syndrome. Patient come with moon faces, buffalo hump and all that. Because patient don't have here dyspnea and cough and hemoptysis. The lung cancer secrete ACTH in the blood and that ACTH is leading to Cushing syndrome and patient presents with Cushing syndrome. I hope you are getting it. So you have to learn this list. So sometimes the lung cancer patient again present with inappropriate antidiuresis. Inappropriate antidiuresis because here the lung cancer patients secrete ADH and the symptoms are due to increased ADH in the blood. Sometimes the pancreatic cancer presents with hypoglycemia because it is secreting insulin in the blood. So you have to learn this list. Learn the name of the cancer, learn what it is secreting in the blood, and because of that thing, what the symptom is produced, that is paraneoplastic syndrome. So please learn as many examples as you can. At least I will advise you to learn at least 10 examples for your exam. So at least if you are getting a 3-mark question, you should quote 10 examples of paraneoplastic syndrome. So please learn as much as you possible. So learn the name of the cancer, learn the thing which is just secreting in the blood, and learn the syndrome because of which that it is leading to paraneoplastic syndrome. I hope you got it. So what is paraneoplastic syndrome? What is paraneoplastic syndrome? So here the patient of the neoplasia do not complain of primary cancer. The symptoms are unrelated to the primary cancer, which cannot be explained directly or indirectly or with distant spread of the cancer. So those symptoms are paraneoplastic syndrome. It is due to secretion of certain hormones by the cancer cells in the blood, and those hormones are producing certain symptoms which are unrelated to the primary cancer. So you have to learn at least 10 examples for your university exam. But if you are preparing for any competitive exam, I suggest you to learn this complete table. In MCQs, you can get any of the question. So that's all about it. So we have seen all the clinical features of the cancer, in which we divided the cancer clinical features under 2 headings, the local effects and the systemic effects. In the local effects, we have seen the compression. The best example is BPH. The second is obstruction. The best example is intestinal obstruction, tissue destruction, infarction, ulceration. In the systemic effects, we have seen the cachexia, 3 mechanisms of cachexia. Fever, told you the mechanism of fever. Tumor lysis syndrome, I told you the 4 properties of tumor lysis syndrome, that is hyperuricemia, hyperkalemia, hyperphosphatemia and hypocalcemia. I told you the reason for each of them and the consequence of each of them. So you have to learn that. And paraneoplastic syndrome, you have to define paraneoplastic syndrome and tell at least 10 examples of that. 10 examples of that. So I guess you got it. Don't forget to have a look on long, short and very short and MCQs of this portion in the question bank as well as notes, so that you will become confident that you can answer any of the question from this section. That's all about it. Thank you. Hello everyone, here we are going to cover grading and staging of cancer. You usually get a short question either on grading or on staging or both of them, but you never get long question on that. So short or very short question on them. So let's start. It's a small topic, grading and staging of cancer. So you can see we are starting the topic, that is grading and staging of cancer. So first I will let you know the introduction, why grading and staging is important, what is grading, what is staging, and one of the important system of staging, that is TNM staging, we will see in detail. Okay, so grading and staging are two different things. Many students have confusion or misconception. They think that grading and staging is one and the same thing. We divide the cancer into 4 grades, 1, 2, 3, 4. We divide the cancer into 4 stages, 1, 2, 3, 4, but they are different things. So let me start with the introduction. What do you mean by grading and what do you mean by staging? Both of them are necessary to predict the prognosis of the cancer, to predict the tumor behavior, the prognosis of the tumor, the prognosis of the cancer, and to guide the therapy, grading as well as staging. So grade 1 and stage 1 tumors have favorable prognosis, good prognosis, and grade 4 and stage 4 cancer have poor prognosis. So they are required to predict the prognosis, and stage wise and grade wise the treatment can be different. So they are required for two purposes. Number 1, to predict the prognosis of the tumor or cancer, and number 2, to guide the therapy, because different stages and different grades can have different treatment therapies options available for them. And grade 1 and stage 1 always have better prognosis, good prognosis, as compared to grade 4 or stage 4. So what do you mean by grading and what do you mean by staging now? Grading is the gross and microscopic appearance of a cancer based on the degree of differentiation of the tumor. I will let you know what is degree of differentiation. And staging is the extent of spread of the tumor within one patient. So let me explain you in two diagrams. For example, the patient is having a cancer in the stomach. For example, this is the gastric carcinoma in a patient. There is a patient having gastric carcinoma here. Let me draw the tumor here. So this is the tumor I'm drawing here, and this is the tumor I'm drawing here. So for example, this is the normal cells of the stomach. These are the normal, the blue one are the normal cells and the red one is the cancer cell. So I have to see the degree of differentiation. The tumor cell, how much they resemble the normal cell. That is the resemblance, the extent of the resemblance is known as differentiation. So how much the tumor is looking like the normal or how it is different from the normal, that will decide the grade. So for looking to it, we require microscope. So grading is always done by pathologist. It is always done by pathologist. It is based on the microscopic appearance. Microscopic appearance of the cancer cell. The red cell, how much they resemble the blue cell. I mean the tumor cell, the red cell is the tumor cell. How much they resemble the normal cell. The percentage of the resemblance or the percentage of difference. For example, 50% are resembling, 50% are different, for example. So this is the grading. I will tell you the details. This is grading. And what is staging? Now here you can see the tumor. This tumor can show the metastasis in multiple organs. The multiple secondaries are formed. So the extent to which it is spread it to the lymph nodes and spread it to other organs. The extent to which the spread of the tumor is there. We are looking the spread, how much the tumor is spreaded in the entire body, and that decides the stage. Staging is regarding the spread. You can learn S for S. Staging is regarding the spread of the tumor, and grading is regarding the microscopic resemblance of the tumor cell with the normal cell. I hope you are getting the 2 points. What is grading? What is staging? So grading is done by the pathologist because it requires the microscopic appearance. Microscopic appearance is done only by pathologist. Staging is the spread of the tumor. How much the tumor is spread in the entire body. We predict it with various tests like the PET CT scan. So it is done by the clinician. It is done by the clinician. And this one is done by the pathologist. I hope you are getting what is grading and what is staging. What is grading and what is staging? Grading is microscopic appearance, microscopic resemblance of the tumor cell with the adjacent cell. That is grading. And what is staging? Staging is the spread of the tumor in entire body. How much? The extent of the spread of the tumor. Grading is done by pathologist. Staging is done by the clinician. I hope you got the basics. So same thing is written in front of you. That is the introduction. With this introduction, I told you the grading is done on pathological basis and the staging is done on clinical ground. So this one is done by pathologists. This one is done by the clinicians. Now we will see the details of both of them one by one. Let's start with grading. I told you it is the gross and microscopic degree of differentiation of the tumor cell from the adjacent cell. Now you can see in this diagram the pink cells. Can you see the pink color cells? These are the normal cells of that tissue. For example, it is breast. So the pink cells are the normal breast cell. For example, it is stomach. So pink cells are the normal stomach cells. For example, it is brain. So pink cells are normal brain cell. So whatever tissue it is, in which organ the tumor it is that, the pink cell are the normal cell of that organ. I hope you are getting it. What are the blue cells? The blue cells are the cancer cell. Now, please, microscopically, you see the cancer cell, how much they resemble the normal cell, or it is different or it is resembling. Tell me the percentage. So out of total 100 cancer cell, only 25% are anaplastic. Anaplastic means they are different, and 75% are still resembling. It is known as grade 1 tumor. In grade 1 tumor, the 75% of the cancer cell, they resemble the normal cell. 25% are anaplastic. Anaplastic means they are different. It is known as grade 1. So in grade 1, 75% are resembling and 25% are anaplastic. In grade 2, 50% resemble and 50% are anaplastic. 50% resemble with the normal cells, the pink cells, and 50% of them are not resembling. They are anaplastic. In grade 3, 75%, 25% are resembling and 75% are not resembling. They are anaplastic. And in grade 4, more than 75% are anaplastic and less than 25% are resembling. So that is grade 4. So we have 4 grades: grade 1, grade 2, grade 3, grade 4. This grading system is known as border grading. So basically, in a group of cancer cell, have a look here. Have a look here. So for example, I'm having 100. We talk in terms of percentage. That's why I'm saying 100. For example, I'm having 100 cancer cell. You can see here. So we talk in terms of percentage. Out of the 100 cancer cell, how many of them are resembling the normal cell and how many of them are different from the normal cell? If 75% are resembling and 25% are anaplastic, anaplastic means different, it is known as grade 1. If 50-50, 50% are resembling and 50% are anaplastic, it is grade 2. In grade 3, only 25% are resembling, but 75% are different. It is grade 3. And in grade 4, maximum are different, although all 100 are different. Means more than 75% are anaplastic, it is grade 4. This is border grading system. That depends on the microscopy. We cannot decide the grading without microscope. So you have to put the slide of the cancer cell under microscope, in which you can judge a percentage, how much tumor cells are resembling the normal cell or they are anaplastic from the normal cell. So based on that percentage, we decide the grade of the tumor. Grade 1, grade 2, grade 3, grade 4. Grade 1 is known as well-differentiated tumor. Grade 2 is moderately differentiated. Grade 3 is also moderately differentiated. And grade 4 is poorly differentiated tumor. So you have to understand the grading. It is based on the resemblance of the tumor cell with that of normal cell. The percentage of the resemblance of the tumor cell. So for example, there is a breast cancer in a female. She's a female and she's having the breast cancer. So this is red cells is the breast cancer cell. And the blue cells are the normal cells of the breast. So you have to tell me in the tumor, how much percentage of the red cell are resembling the blue cell and how much percentage is not resembling, that is the anaplastic. Based on that, we can decide whether the tumor is grade 1, grade 2, grade 3, and grade 4. The treatment of the different grades can be different and the prognosis is definitely different. Grade 1 is having a good prognosis, grade 4 is having a poor prognosis. So based on which we can do the grading. Now coming on the staging. What do you mean by staging? Staging is the extent of spread of the tumor within the patient. Now this is the tumor. Again, let's talk the same. This is a breast cancer in a lady, in a patient, and it is spreaded to multiple organs. The metastasis is there. So how much it is spread? For that we have to do the clinical examination, investigation, radiological examination, based on which we will do the staging. Staging is done by the clinician. There are two important systems of staging, TNM and AJC. TNM is tumor size, nodal status, and metastasis, TNM, that I will tell you in detail. And second is American Joint Committee, AGC, that we will not see in detail. So out of the two systems, we will see TNM staging system in detail. What is the full form of TNM? T means tumor size, N means nodal status, and M whether metastasis. M for metastasis, whether metastasis is present or not. So let's talk about the breast cancer. So for example, there is a patient coming in my clinic. There is a lady who is having a mass in the breast. So first I will judge the T for that lady. T. What is T? There are 4 options of T. Is it T1, T2, T3 or T4? If the tumor, I will do a mammography and I will see the tumor. If the tumor is less than 2 centimeter, it's T1. If it is 2 to 5 centimeter, it's T2. If it is more than 5 centimeter, it's T3. You see here it's less than 2 centimeter. Here 2 to 5 centimeter. Here more than 5 centimeter. So that's T3. And if whatever is the size of tumor, but if it is infiltrating the pectoralis muscle, ribs, and if it is infiltrating the skin, either downwards or upwards, it is T4. T4 is extending to the skin or the chest wall, it is T4. Whatever is the size doesn't matter. So decide the T for that person. T for that person. Now come on the N. Again, there are four possibilities. No lymph nodes are involved, we will say N0. No lymph nodes are involved, there is no T0, there is N0. Okay. So if no lymph nodes are involved, there is N0. There is a possibility that the lady is having the cancer, but lymph nodes are not involved. If only axillary lymph nodes are involved, but they are movable, it's N1. If axillary lymph nodes are involved, but they are fixed now, it's N2. If along with the axillary, supra and infraclavicular lymph nodes are also involved, it's N3. So we have to see which lymph nodes are involved and decide the N for that lady. And then we have to decide the M. For doing the M, we have to do the PET-CT. Do the PET-CT and see only two options. Metastasis is absent or present. If no metastasis, the tumor is confined only to the breast, say it is M0. And if it is spread to one organ, maybe liver, bone, brain, or any of the organ or multiple organs, it's M1. So M0 or M1. So in M, we have only two options. So first, whenever a lady is coming to my clinic having any cancer, for example, the lady is coming with a complaint of the breast cancer. So this is a rough sketch diagram, line diagram of a lady having the breast cancer. Okay, so let's draw a breast cancer here. So I have to decide the staging. For staging, I cannot decide. There are four stages. Stage 1, 2, 3, 4. I will come on that. How I will decide the stage. For that, I have to judge three things. First decide the T, decide the N, and decide the M for that lady. In the T, I'm having four options: T1, T2, T3, T4. If the tumor, I will do a mammography and see if the tumor is less than 2 centimeter, it's T1. If it is 2 to 5 centimeter, it's T2. If it is more than 5 centimeter, it's T3. But if it is involving the skin or the chest wall or the ribs, it is T4, whatever is the size. Then I will decide the N. In the N, I'm having four options: N0, N1, N2, N3. If no lymph nodes are involved, it's N0. If along with the breast cancer, axillary lymph nodes are involved here, but they are movable, it's N1. If they are fixed, axillary lymph nodes, it's N2. Along with the axillary, if the supraclavicular and infraclavicular, supra and infraclavicular lymph nodes are also involved, it's N3. So that is the N. And do a PET-CT and see whether METS is absent, M0, or METS is present, M1. So in the PET-CT, you will come to know that. So decide, now there are various combinations. Maybe it's T1, N0, M0. Maybe T2, N1, M0. So various combinations are possible. So first have a look on the T, N, and M, and then decide the stage. Can you see here? Can you see here the tumor is very small, less than 2 centimeter. Here it is 2 to 5 centimeter. Here it is more than 5 centimeter maybe. Okay. And here whatever it is involving and it is metastatic basically. So we have to decide the stage. There are four stages: stage 1, 2, 3, 4. In stage 1, it is T1. But no nodes involved, no metastasis. And tumor is less than 2 centimeter. That is T is 1, but N is 0, M is 0. We call it stage 1, the best prognosis, stage 1 tumor. In stage 2, T can be 1 or 2. N can be 1 or 0, but there is no METs. So T can be 1 or 2, N can be 0 or 1, but there are no METs. In stage 3, whatever is the T, whatever is the N, but M is 0. Basically, N is 2 to 3 here, but M is 0. There is no METs. In stage 4, metastasis is always present. Whatever T doesn't matter, whatever N doesn't matter, but it is metastatic. M is always 1. And there is no cure for metastatic stage 4 tumor. There is no cure available till date. It is under research, but it is no cure available till date. Stage 1 having the best prognosis, the 5-year survival is 84. So out of the 100 ladies, 84 will survive after 5 years. In stage 2, the 5-year survival is 71. So out of the 100 ladies, 71 will survive after 5 years. In stage 3, the 5-year survival is 48. Nearly 50%. So nearly 50% of the ladies will survive after 50 years. But in stage 4, only 18 ladies will survive out of the 100 after 5 years. So look at the 5-year survival rate if you want to know the prognosis. So that is the staging. I hope you got it. So I hope you got how to decide the grade and how to decide the stage. Here also we have 1, 2, 3, 4 grade. Here also we have 1, 2, 3, 4 stage. For grading, I told you border system in which we decide the grade based on the percentage of anaplasia. And here I told you TNM, in which we decide the stage based on the T, N, and M combination. So that's all about it. I hope you got it. You get a short question on that or very short question. So have a look on the short, very short questions and MCQs of this topic given in your notes section. Thank you so much. Hello everyone. In this session, we are going to discuss lab diagnosis of cancer. Now, you usually get a long question on that, so you have to write down the 6 ways of diagnosing the cancer. I will discuss all 6 here. And sometimes you get a short question on individual ways of lab diagnosis of cancer. The most important among them is the tumor markers. You frequently get a short or very short question on the tumor markers or the example of tumor markers. Or sometimes you get a short or very short question on other methods also, like the immunohistochemistry or cytochemistry or cytological methods or FNAC. So we will be discussing all 6 ways of diagnosis, the lab diagnosis of cancer or neoplasia. Let's start it. So here you can see we are starting the topic that is lab diagnosis of cancer. Although all 6 are important, but ultra important in it is tumor marker, on which repeated question is asked in the university exams. So let's start. So as I told you, there are 6 ways of diagnosing the cancer. They are in front of you. Number 1, it is histological method. We will be discussing that. Number 2, it is cytological method, in which there are 2 methods, exfoliative cytology and FNAC. We will discuss both of them. Number 3, it's histochemistry and cytochemistry, in which we will discuss the special stains. Number 4, it's immunohistochemistry. Number 5, it's electron microscopy. And finally, the most ultra important, it's tumor marker. Make a 5-star over it. It's a frequently asked question in your university exam. Now, if long question is asked, you have to describe all of them along with a well-labeled diagram. And if it is a short question, whatever individual method is asked, you have to write that only. So let's start with the first one, histological method. In histological method, there are 2 techniques. Number 1, paraffin embedded technique, that is the routine technique, and second is frozen section. For the reporting in paraffin embedded technique, 3 to 4 days are required. That is 72 hours, minimum 72 hours or more than that is required for reporting. Frozen section has to be reported within 15 minutes, 10 to 15 minutes, not days. So it is a fast technique. This one requires more time but more accurate. We will be discussing both of them one by one. First of all, what do you mean by histological method? The most important way of diagnosing cancer. Now, for example, there is tumor. You can see this is cancer. This can be cancer of any part of the body, and the surgeon have operated it. Once the surgeon have operated it, the surgeon have sent the specimen. The surgeon have sent the specimen to the laboratory, the histopathological laboratory. You can see this is a cancer, and the surgeon have operated the patient, and the surgeon have sent the specimen to the laboratory. Now, it can be a specimen, sometimes it can be a biopsy also. It can be complete specimen or it can be a biopsy. Now, I'm a pathologist. I want to have a look on the slide of this tissue. How I convert this tissue into slide? So it requires 6 steps in which I can convert this tissue. You can see this is tissue. I want to convert this tissue into H&E slide, so that I can examine it and I can have a look on it and I can comment whether it is benign tumor or malignant tumor, and I can give the diagnosis. Okay, so how to convert the tissue into the slide? It requires 6 steps. That is the paraffin embedded technique. So what are the 6 steps? First of all, we will give the cuts in the tissue, proper cuts. We will give the cuts every 0.1 centimeter. Ideally, we should give the cut into slices into every 0.1 centimeter, and we should fix it in the formalin. You can see we can take the container contain the formalin, and we put the tissue, the slices of the tissue into the container, so that now this tissue is out of the body of the patient. Till the tissue is inside the body of the patient, it's viable. Once you cut the tissue, the surgeon have cut the tissue and surgeon have taken the tissue out of the body of the patient. Now the autolysis will start. So before I make the slide, what if the complete tissue is autolyzed? I can't see anything. Autolysis is necrosis, complete dead tissue. I cannot see anything. I cannot afford that. I want to fix the tissue. So that is known as fixation. The first step is always fixation. Fixation is done in 10% buffered formalin. So that is the fluid we are taking. That will fix the specimen in whatever condition it is. So it will be fixation, and no, after fixation there is no autolysis. So minimum duration of fixation is 24 hours. We do the fixation for 24 hours. So I am a pathologist. For example, you are a surgeon. You have operated a patient and this is the cancer. You have sent it to my laboratory and you have given a call that, ma'am, have a look and tell me the diagnosis. So what I will do, I will give the cuts in that every 0.1 centimeter. I will take the measurements and I will put that specimen into the 10% buffered formalin for the next 24 hours. After that, I will put the pieces into the tissue pieces into the cassettes. The cassettes are available and I will put it for processing. Now, this is the instrument known as tissue processor. So I require this instrument and I will put it for processing for overnight at least 12 hours. There is a 12-hour program. There is an automated program. So I will put, so there are various containers which contains various chemicals. So one by one, it will be shifted. So first it will go in alcohol, then it will go in this and this. Likewise, it will be shifted in various containers. So it is processing is done. After that, we take the cassettes out and we will do the embedding. The third step is embedding. First, we do the fixation. We are converting the tissue into the slide. Please understand. So first take 10% buffered formalin, take your specimen, cut it into pieces, take the formalin in a container. The size of the container should be 10 times, at least 10 times as compared to the size of the tissue. So if the specimen is big, big container is required. If the specimen is small, small container is required. So size of container should be 10 times as that of the specimen. Fill it with 10% buffered formalin and put the slices in that and keep it there for 24 hours. After that, take out the slices, cut into pieces and fill it in cassettes and put the cassettes into the tissue processor and leave it there for the next 12 hours or overnight. You can say overnight. After that, we will do embedding. What we will do? After that, we will do embedding. In embedding, what we will do? We will take the tissue out and we will take a cassette. Can you see? This is a cassette. Appreciate. I will show you the videos also. Wait. So have a look. This is a cassette. After the images, I will show you the video so that you have a better understanding. Now, the cassettes are of two types. The plastic cassettes and metal cassettes, both are available. So, in the cassette, we take wax. We take wax. You know what is wax? Wax has a property. When you heat the wax, it melts. And when you cool the wax, it will solidify. It will solidify. So this is the property of the wax. When we are heating, it is melting. When we are cooling, it will solidify. Got my point? That is the property of the wax. So basically, for example, this is the cassette. This is the cassette. We are filling it with, we are heating the wax and filling it with the melton wax. So this is complete melton wax. We are heating the wax and filling the cassette with melton wax and putting the tissue in that. So this is my tissue. I have put my tissue piece in that. So what will happen? My tissue will fall by gravity and it will be here. So this is my tissue. This is my tissue. So as soon as I will put my tissue in the melton wax, then I will keep the wax on the ice piece. On the ice piece so that it can solidify. I'm cooling it. I'm cooling the wax so that it can solidify. So it will be completely solidified. It will be completely solidified and the tissue get embedded in that. So I got a cutting medium. So this is known as embedding. I hope you got it. I'm repeating. So I'm taking a cassette. I will show you the video. Wait. I will take a cassette. In the cassette, I will fill the melton wax. The heated wax. The melton wax. I repeat my words. I will fill it with the melton wax. And then I will put my tissue in that. This is my tissue I'm putting in that. So the tissue will fall due to the gravity at the bottom of the cassette. And then I will put it on an ice piece. I will put the cassette on the ice piece so that it can cool and it can solidify. Now it is solidifying. It will be completely solidified like that. Right? It will be completely solidified. Then I will take this wax block. It is known as block, paraffin block. The wax block out. So it is like that. So it is the complete block of the wax. It is a complete block of the wax. I will take it out of the cassette. It is inside the cassette. Now I will take it out. It is complete block of the paraffin wax. And here there is a tissue. Here there is a tissue and I can cut it into multiple pieces. So this is known as embedding. The embedding is done. I will show you the videos. After that, I require an instrument which is known as microtome for cutting. Microtome. I will fix the paraffin wax block into the microtome and I will cut it into very thin slices, like I will cut into 5 micrometer. The standard is 5 micrometer, 1 micrometer to 5 micrometer, very thin. 5 micrometer is the thickness, very thin slices. You can see the slices, very thin slices one by one. You can see this is paraffin block and there is a knife, there is a blade in the scalpel which is doing cutting. So that is microtome. After that, we are taking it on a slide, doing the staining, HNE and examine under the microscope. So these are the 6 steps. I will show you the video. First of all, we are doing the biopsy. Either you are taking the specimen, the surgeon is performing the surgery and sending the specimen to us, or the surgeon is performing the biopsy. What is biopsy? A core of tissue. What is biopsy? Biopsy is a core of tissue. It is performed with a gun. You want to see? See. Now this is a gun, the biopsy gun. It is taking the tumor tissue out. So this tissue is the biopsy tissue. Okay, so we receive either the big specimen or a small 1 centimeter, 0.5 centimeter biopsy. Whatever I am receiving, it is a tissue. The tissue can be of two types. Either I am receiving a specimen or I am receiving a biopsy. Whatever I am receiving, I will put it in formalin for the next 24 hours. So first step is fixation. I will show you the 6 steps. Please concentrate. The first step is fixation. Fixation is done in 10% buffered formalin. Please mind it. It is asked in vivas also. 10% buffered formalin. You can see here. You can see here. The container contains the buffered formalin. We are putting our tissue in that. The tissue can be biopsy, so container is small. The tissue can be big specimen, so container is large. But both contain 10% buffered formalin, and we do it for 24 hours. Leave it there for 24 hours. You can see there is a clock showing 24 hours. So for 24 hours, we are doing the fixation. After that, we are cutting into pieces on a board. You can see and filling it in the cassette. This is the tissue which is already fixed, in the formalin. Now you take out, you cut it into pieces with the scalpel and put it in the cassette. Can you see? This is the cassette. The plastic cassettes can be there. Okay. So after that, this is the tissue processor. Keep it in the night. And usually in the night programming is there. So we keep it in the tissue processor and we set a program for 12 hours. Overnight. So some programs are 8 hours, some are 12 hours, different programs are there. But usually we do it for 12 hours overnight. So various containers. So this tissue will go one by one in all containers. So at the end of the 12 hours, it is automated. At the end of the 12 hours, the completely processing is done. This instrument is known as tissue processor. So first we are doing the biopsy. Okay. After that, we are doing fixation. The first step is fixation. After fixation, we are doing tissue processing. After cutting, we are doing tissue processing. Second step is tissue processing. After that, we are doing embedding. See, this is a block. Can you see? In the block, I have first filled with the molten wax. See it again. See, I'm filling the block with the molten wax and putting my tissue. See, my tissue is inside, and due to gravity, it is settling down. And after that, I will cool it. After that, I will cool it. After that, I will cool it and take the block out. You see, I'm taking the block out. It is already cooler. So it is solidified, not is completely solidified. First, I'm filling it with the liquid wax, molten wax. I'm putting my tissue and then taking the block out. So it is solidified now. Now, after cooling, I'm taking. So it is the block. This one, the person who is taking out this one, this is known as paraffin wax block. Paraffin wax block. I'm taking out of the cassette. This is a cassette. You see, this is a cassette. This is a cassette. So in a cassette, we are first putting the liquid wax. Then we are putting our tissue in that. The tissue will settle down. Then we are cooling it, solidifying it, and taking the block out. So this is how the block is taken out. I assume you can see the block is taken out. So this is known as embedding. Now I'm having a block with a tissue on that. So finally I'm having a paraffin block on which the tissue is there. Now this instrument is known as microtome. So can you see the block? I have fixed the block here. Can you see? Here. This is my block with tissue. Can you see? And I'm running the paddle, and with that I have set the thickness I want. So I've set the thickness 5 micrometer, 3 micrometer, whatever. So thin slices are cutting on the paraffin wax. So this is known as cutting and trimming. So we require an instrument that is known as microtome. So this is microtome. On microtome, we are doing cutting and trimming, and we are putting it in the water. So these are the thin slices I am cutting so that it remains straight. I'm putting it in the water, and from the water, I will take it on a slide. Can you see? I will take it on a slide, and after that I will stain it. So this is on the slide. Now I got the tissue on the slide, and finally I will stain it with H&E. So there is a proper technique. We will stain with H and E. So H is hematoxylin and E is eosin. We will stain it with H&E and examine under the microscope. So these are the steps. I hope you got the 6 steps. What are the 6 steps? Can you enumerate now? Now you can imagine I've shown you the videos also. Number 1 is fixation. We will do it in 10% buffered formalin. Number 2 is processing in a tissue processor for overnight program. Number 3 is embedding. Embedding is done in wax. First, we take the molten wax, put the tissue, and then we will cool it and solidify it and take out the block. We get a paraffin block. After that, we will fix it in the microtome and do the cutting and trimming in the microtome. You can see cutting and trimming. Then we do the staining. Staining is done with H&E. The staining is done with H&E. You can see. Just a second. We are doing the staining with H&E. And finally, we are examining under the microscope. So please see the 6 steps. We are done with that. Now I am teaching you the histopathology, the histopathological technique. The first was paraffin embedded block. We have done that. Now the second is frozen section. What is frozen section? Frozen section is a technique in which the surgeon who is operating the patient intraoperatively, when the surgery is going on, at that time take out a tissue from the body of the patient during surgery and give it to the pathologist. Give it to the pathologist and ask the pathologist to report it within next 10 minutes. 10 minutes. The complete process, this requires 3 to 4 days. You require 24 hours here, you require 12 hours here, and the cutting, trimming, staining requires another 6 hours, and availability of the pathologist and reporting requires another few hours. So it requires 2 to 3 days. You got my point? But frozen section has to be reported within 10 minutes during the surgery. The patient is on table. The patient is under anesthesia. Based on the report, the surgeon will take a call further how the surgery has to be done. For example, the best example I can quote you here, there is a female. The female is having a breast cancer, and there is a surgeon. For example, you are the surgeon who is operating this female. She presented with breast cancer. This is the breast cancer. You have done a biopsy. For example, this is the breast of the female, and she is having a cancer in one of the breasts. You have done the biopsy, and in biopsy it's malignant, it's not benign. So you are operating this female. In operation, in surgery, you have already taken the tumor out with clean margins, with clean boundaries. You have done the lumpectomy, right? Now you will give one more incision. So let me ask you a question. Whether you will take the axillary lymph nodes out, yes or no? Whether you will take the axillary lymph nodes out, yes or no? My question to you. Because we know that breast cancer spread via axillary lymph nodes. What if you have already taken the tumor out, but the cancer have already spread it to the axillary lymph nodes? So you are leaving the tumor in the body of the tumor. You cannot afford that. So you will say, ma'am, I will take this also out. So I will take the tumor also, and I will take the axillary lymph nodes. But if you take the axillary lymph nodes out, these are not vestigial organ. They prevent edema. So after the surgery, the patient will have edema of the hand, lymphoedema. The patient have edema throughout the life. So the female is concerned. The female is saying that, doctor, definitely you are going to remove my tumor. I want you to remove my tumor. But I want you to confirm if my lymph nodes are involved, then definitely you remove it. I will bear edema throughout my life. I do not want to die. So I will live with edema. It's okay. But if they are not involved, why unnecessary you are giving me the edema? So during the surgery, can you confirm whether my nodes are involved or not? So here is the role of the frozen section. So the first node is known as sentinel lymph node, the first node. So first node is taken out by the surgeon and given to the pathologist. One node, the sentinel lymph node. The first node is taken out by the surgeon and it is given to the pathologist. And the pathologist is asked to give the report within next 10 minutes whether this node is involved or not. Now, just suppose I am the pathologist in your OT and you are performing this surgery. You have taken the first lymph node out and given it to me. And you are asking me, ma'am, can you please tell me whether this node is involved or not? Based on which my further course of action is decided in the surgery. If you say, yes, this node is involved, yes, I will take out all the lymph nodes. Because I cannot take a chance. The first is involved, maybe all are involved. But if you say the first node is not involved, it's clean, it's not involved, I will leave the other lymph nodes and just suture the patient and take it out. So based on your decision, based on your report, my further action is dependent. So here, frozen section is the procedure which is carried out during the surgery. Here, directly unfixed tissue. We don't fix it. Now you are a surgeon. You have given me the first lymph node, the sentinel lymph node. This is the lymph node you have given to me and asked me to give the reports in 10 minutes. Normally, if you give me this lymph node, normally, if you send it to my laboratory, I will fix it for 24 hours first. The first is the fixation. Then for 12 hours, I will do the processing. I will require nearly 2 to 3 days to report it. But now you are asking just in 10 minutes. I will not fix it. I will just process it directly, unfixed tissue only, unfixed tissue. So if I'm taking the wax, if I take the wax has a property when it is heated, it is molten. When we cool it, it will solidify. But when we take the wax now, we can take the wax in case we are doing the processing. Here we are not doing the processing. We are not doing the fixation. We are directly using the unfixed tissue. So instead of wax, we use water as a medium. Here we were using the wax as a medium. This was the wax block on which this is my tissue and I was cutting it. I was using the wax as a medium. Here instead of wax, I will make a water block. Water also have the same property now. When we heat the water, it's liquid. When we cool the water, it's solid, it's ice. So instead of wax, we are taking the water and we are making a block of the water. This is our tissue. So the same thing is there. So we will take a cassette. We will fill the cassette with water. It's a special water. We will fill it with water, not wax. We will fill it with water, normal water. And then we will put the tissue given by the surgeon here. The surgeon has given the tissue and asked us to report in 10 minutes. So the tissue will go down. And there is an instrument which is known as cryostat. That instrument have the temperature of minus 70 degrees. So we will put that block inside this instrument. So as soon as you put within few seconds, maybe 10 to 20 seconds, it will solidify. Because the temperature is minus 70. Now at minus 70, everything solidifies. So here this will solidify. You take it out and you just cut it. You just cut it likewise. So you can see this is the block. It don't have wax. This is the tissue. This is the tissue provided by the surgeon. And this is the block, this one. You can see this one. But it contains water, it don't contain wax. So we are putting it in the cryostat. This is the instrument having minus 70 degree. And once we have done the cutting, we will stain it and we will see it and we will report. Intraoperatively, the surgeon will take the decision based on that. So surgeon and pathologist together have a look on the slide and they decide the further course of action. The name of the instrument is cryostat machine. So see, I will show you a video. So see, here we are taking the water we have taken, we have put the tissue on the water, we have put the tissue, this is the tissue we are putting with the forceps, you can see, and we will put it, this is the water we have taken, see again, and this is the tissue with the forceps we are putting it. Now we will put that block into the cryostat machine. Within few seconds it will solidify. Within few seconds it will solidify because the temperature here is minus 70 degrees, and we are getting the block and we are directly cutting it in the microtome. After cutting, we are staining it, you see, we are cutting it and putting it on a slide. And we will stain it. After staining, we will have a look here and we will decide. So this is frozen section. I hope you got it. We are done with the histopathological technique. Now coming on the cytological method. Now first I taught you histologic methods. In histology, I taught you two methods: paraffin block, paraffin embedded block, and second is frozen section. In both of them, we take out the tissue. Either the tissue is biopsy or the complete specimen, but it is a tissue. Here we are doing the reporting in 24 to 48 hours or maybe after that. But here we are doing the reporting in 10 minutes. Here the medium we are using is wax. Here the medium we are using is water. That is the difference. But here we are taking out the tissue. Now I'm telling you the cytological method. Here we don't take out tissue. Here we were taking out tissue. Here we take out cell from the body of the human. From the human body, we take out the tumor cell. We don't take out tissue, we take out cells. So that is the meaning of cyto. Cyto means cells. We are doing examination of the cell. We don't do examination of the tissue. So please understand the meaning. Histology and cytology. Histology and cytology. Logy is the study. What do you mean by logy? Logy. Logy means study. Study of what? Histo means tissue. It is the study of tissue. So we take out tissue and process it. And cyto means cell. So it is the study of the cell. Here we are taking out tissue and looking at it and reporting. Here we take out cell. We don't take out tissue. So that is the cytological method. So first we have seen the histological two methods. And now in the cytology also we have two methods. Exfoliative cytology and FNAC. Now what is the difference between them? Exfoliative cytology and FNAC. What is FNAC? Fine needle aspiration cytology. FNAC. Fine needle aspiration cytology. In exfoliative cytology, whatever tissue is already shedded by the body, we don't shade it. It is already shedded tissue. We just take it out and stain it and see it. In FNAC, first we separate the tissue from the tumor. Then we will take it. Here already shedded. Here we will do the shading. That is the difference. Please understand. So let's start with the first one, exfoliative cytology. So just suppose there is a patient having a tongue tumor, having a tumor in the oral cavity. So we take a brush. Can you see? This is a brush, or we take a spatula. We just, with the brush, we will collect the cells over the tumor, or with the spatula, we just collect it. They are already shedded. So we are doing the microscopic examination of already shedded cells, which are present on the surface of the tumors or the lesions. We just collect it and stain it. We are just collecting it. So with the brush, we are collecting it and we will take it on a slide. We will stain it and see it. That is exfoliative cytology. So it is useful in cervix cancer, endometrial cancer, lung cancer, bladder cancer, prostate cancer, stomach cancer, where the shaded cell we just collect with a brush or a spatula. We just collect it from the brush or a spatula. That's it. The shaded, already shedded cells from the body. The tumor have already shedded these cells. We are just collecting it on a slide, doing the staining and examining it. So exfoliative cytology. But in FNAC, the cells are not shedded. Now, for example, there is a breast tumor. Can you see? This is a breast tumor in a lady. This is a breast tumor. So we will take a syringe with a needle. We will take a fine needle with a syringe attached, empty syringe. It don't contain any medicine, any drug. It's a syringe with a needle, very thin needle attached to it. And I will insert, no anesthesia is required. I will put the needle inside the tumor and do to and fro motion. So you can see it here. Can you see? So first, with two hands, first hand, just suppose I am performing the FNAC on this lady and the lady is having a mass in the breast. So with one of the hand, with maybe I'm a right hander. So with my left hand, I will fix the tumor. So you can see I have fixed the tumor here. The first thing I will do, I will fix it. I will palpate it everywhere and I will fix it. Number one. Number two, I will put the needle inside that. The needle, very thin needle. And I will do the to and fro motion like this. To fro inside the tumor. So what will happen? Why I am performing the to and fro motion? So inside the tumor, the cells will get dissociated from each other because of the to and fro motion. The cells are not already shedded. We are doing the separation. So for few seconds I will do, it's little bit painful, not much, but we don't give an anesthesia. So first fix it, then put the needle and do the to and fro motion, then aspirate. So here bleeding will take place inside the tumor, bleeding will take place, and the cells are also separated from the main tumor, and we just aspirate it. We take the plunger out, we just aspirate it. So little bit of the fluid, blood along with the cell will come here inside the syringe. We will transmit it on a slide, we will make a smear, stain it, and examine it under microscope. So we can see the cells. We don't see the tissue. We have separated the cells from the tumor and collected that cell. So first palpate the nodule, palpate the tumor, then aspirate it by doing to and fro motion, do the aspiration, then make a smear on the slide, stain it, and do the microscopy. So this is FNAC, fine needle aspiration cytology, because with the help of a fine needle we are doing the aspiration and doing the cytology. So that is fine needle aspiration cytology. I hope you got it. Now I taught you two methods till now. First method was histology. There were two methods there, and here cytology. In the cytology also two methods are there. Yes or no? In the histology, the two methods, the main was paraffin block, and we have seen frozen section also. Frozen is not very important, but I've taught you that also. Here one is exfoliative and one is FNAC. Here FNAC is main thing. So I want to tell you the which is better. You tell me which one is better. Histology is better or cytology? Histology, we are doing the examination of tissue. Cytology, we do the examination of cells. See, here we are taking out, this is, you can see, everyone here. So here we are taking out tissue. It is the study of tissue. We are taking tissue out. And here we are taking cells out. By doing the aspiration, we are just taking out the cells, not the tissue. So what is the difference between surgical biopsy and the FNAC? Sometimes you get question on that. Now this is histopathology, this is cytopathology. Here we do examination of tissue. Here we do examination of cell. You can see here tissue is taken out and examined. Here cell is taken out and examined. Okay, right. Here anesthesia is required. It's painful. Here no anesthesia is required. It's little bit painful, but the patient can bear it. So here anesthesia is required. Here no anesthesia. Here the length minimum 2 to 4 days are required, because after taking I will fix it for 24 hours, then process it for 12 hours in the tissue processor. Here just I hardly require few minutes now. I will fix it, do to and fro motion, aspirate, take a slide, make a smear, do the staining, examine under microscope. Maybe within 20 minutes, 30 minutes I can do that. So it can be done less than 5 minutes also, very fast. So it is very fast. Here the report is the, okay, length of procedure. Here more than 5 minutes, here less than 5 minutes. Here report is available after 2 to 4 days. Here report can be available after 2 to 4 hours. Within 30 minutes we can give as early as the report. Right, here the cost is very high, because here the consumption is more and it requires anesthesia also. Here cost is low. This one is cheap. The cost is low. Here the trauma is more. Here trauma is less. Here you can see the architecture well. Here you can see the cells well. Here you cannot see the cell morphology well. Here you can see the architecture well, how they are arranged, the arrangement. Here we don't see the arrangement of the cells. The cells are dissociated from each other. We can see the morphology of the cell well. So both of them have their pros and cons, and you have to learn them. So coming on the third method, till now we have completed two. Coming on the third method is histochemistry and cytochemistry. Histochemistry and cytochemistry, these all are the special stains which are staining the special tissue. Sometimes you get a separate question on that. For staining basement membrane, we use PAS, periodic acid shift, or we can use reticulin, or we can use von Gemsa, we can use meson-trichome. For staining glycogen, we use PAS with diastase loss. For staining glycoprotein, we can use PAS with diastase persistence. For acid mucin, we can use Alcian blue. For silver, agrophilic tissues, granules, we use silver stains. For nucleolar reasons, we use colloidal silver stains. So these are the special stain. You can learn a list or few examples. Now the next is immunohistochemistry. What do you mean by immuno? Immuno means antibodies. So how many type of tumors are there? So there are basically 5 different types of tumors. Epithelial tumors are carcinomas. Mesenchymal tumors are sarcomas. Okay. Lymphomas are the lymphoid tumors. Neural origin tumors, and the skin tumors, sometimes melanomas. So sometimes just suppose you are doing a biopsy and the tumor is completely undifferentiated. You're sending the biopsy to me, ma'am, what is it? Kindly tell me the lineage. Is it a carcinoma? Is it a sarcoma? Is it a lymphoma? Is it a neural tumor? Or is it a melanoma? For example, it's a retroperitoneal tumor. It can be anything. I don't know. So you are sending it to me. I'm a pathologist. I will make a slide and have a look. But sometimes it's too undifferentiated. I can't identify. I will say, doctor, I can't identify. Is it a carcinoma, sarcoma, lymphoma, neural tumor, or melanoma? I can't say anything. I can't say. So I will use the immunohistochemistry. They have different antigens. So the epithelial markers are different, mesenchymal markers are different, lymphoid markers, neural markers, and melanotic skin markers are different. Based on those markers, you see this is a tissue. You see this is a tissue. On the tissue, specific antigen is present. Specific antigen. So we use the antibodies against that specific antigen that will highlight that. You got my point? For example, this is the tumor. This is a slide on which I have taken the tumor. I don't know what is this tumor. These are the cells of the tumor. For example, I don't know whether it is carcinoma or lymphoma or neural tumor or melanoma or whatever it is. I don't know, or sarcoma. So it is having antigens on that. No, the antigens which are present on epithelial tumor are not present on mesenchymal tumor. They have specific antigen. For example, I am assuming it's the epithelial tumor. So I will put the antibodies against the epithelial tumor. If the epithelial tumor marker is there, I mean antigen is there, the antibody will bind with it. If it is not epithelial tumor, my assumption is wrong. So antibody will not bind with it and it will wash away. It will wash away. So with the help of the antibodies, we can do the marking like this. So it will highlight like the brown color. Got my point? So that you have to learn the list. So epithelial markers are keratin, pankeratin, epithelial keratin, pankeratin, CKs are there, CK7, CK20, pankeratin. So keratin is a marker of epithelial tumors. Mesenchymal tumors have marker of vimentin and desmin and myoglobin. These are important, you have to learn. Melanotic markers is HMB45 and S100. Learn these two. Lymphoma marker, there are two types of lymphoma, B cell lymphoma and T cell lymphoma. So there is a marker which is common for all lymphoma, that is CD45. In B cell, CD20 is positive, in T cell, CD3 is positive. And in Hodgkin's lymphoma, CD15 and 30 is positive. And neural marker is neurofilament, NF, NSC, GFAP. You have to learn these. Okay, so these are the markers we use here. Now, finally, there is electron microscopy, with the help of which we can see the ultrastructure of a cell. Okay, and finally, we have tumor markers. You get different question on tumor marker, and very frequently you get question on tumor marker in your university exam. Make a 5-star over it. What is tumor marker? What is tumor marker? For example, there is a person having some cancer. For example, the person is having lung cancer. Okay, this is the cancer. The person is having lung cancer. So what are the various methods of diagnosis is available? You will see, ma'am, best is do the biopsy. You just do the biopsy and do the diagnosis, whether it is tumor or not. Okay, we can do the biopsy. I told you the methods. There are 6 steps in the biopsy. I told you histology. Okay, that is the best. But once we have done the histology, now I have started, it's a malignancy. I have started the chemotherapy. I have started the treatment. Now I want to see the response, whether the tumor is responding or not responding, or the tumor is completely cured. I want to see whether recurrence is there or not. So I cannot do the biopsy again and again. First time I have done, but biopsy is troublesome. I have to admit the patient and it's costly also. I have to give the anesthesia. I cannot do it again and again. So I will use the tumor marker here. What is tumor marker? What is tumor marker? Many tumors, not all, many tumors secrete certain antigen or protein in the blood. Certain antigen or protein in the blood. Okay, many tumors secrete a specific antigen or protein in the blood, and we are collecting the blood sample in a test tube. And we are looking for that particular antigen or protein in the blood. If it is elevated, we will assume the tumor is there. If it is not elevated, it's normal, we will assume the tumor is not there. Got my point? So it's very easy test. As easy as you have to just collect the blood sample in a test tube. So if there is a patient in my clinic, I will ask the patient, you have to do the biopsy. The patient will be troubled. I have to admit it's costly. I will be anesthesia. A tissue is taken out of me. But if I say just do the blood sample, just give a blood sample. So patient will be very cool. Yes, I can do the blood sample. I can give the blood sample very easily. So it's very easy to perform. The patient has to give the blood sample or urine sample. So we will test specific protein or antigen in the blood or the urine of the patient which are secreted by the tumor. That is tumor marker. These are the marker of the tumor. So these are the marker of the tumor that are present in the blood or the urine of the patient. These are the biological indicator that the tumor is present in the body. Okay. So this is a tumor. These are the cells of the tumor. This can be any tumor. And this is the blood vessel. So many tumors secrete certain antigens or proteins in the blood. So basically you are collecting the blood sample in a test tube and looking for that particular antigen. So there are 2 possibilities. Either it is elevated or it is normal. If it is elevated, it indicates the presence of tumor. And if it is normal, I mean the tumor is not there. So you can see the response of the therapy. So initially you measure the tumor tumor marker level for any tumor, and after start of the therapy you do it at repeated sequence. So if the level go on decreasing means the therapy is working. Got it? Or if the level is same or it is increasing means the therapy is not working. So it can be helpful in response of therapy or recurrence. But it lacks sensitivity and specificity because many other cells apart from tumor cells also secrete it. So it is not necessary that if particular tumor marker is present in blood, it always indicates that particular malignancy. It lacks sensitivity and specificity. It can be used as a complementary test to histology. So, but the best is to do the histology. For diagnosis, best is histology. I mean, best is to perform the biopsy. And after that, as a complementary test, as the adjuvant test, you can use the tumor markers. It is not the primary test. Okay, it is used for screening, for diagnosis in symptomatic patient, for estimating the volume of the tumor, for looking at the indicator of disease progression, monitoring the therapy, and looking at the recurrence. That is the applications. Now list it. We have to learn the examples. So some of them are hormones which are secreted by the tumor in the blood. Some of them are antigen. Some of them are enzymes. Some of them are protein, and some of them are glycoprotein. Divide them in 5 categories: hormone, antigen, enzyme, protein, and glycoprotein, and learn the particular examples. So among the hormones, the non-seminomatous testicular tumor secrete beta HCG in the blood. So you just suppose there is a patient having a scrotal mass, and I am suspecting the patient is having non-seminomatous testicular tumor. So I will collect the blood sample. If the blood sample contains the beta HCG, human chorionic gonadotropin, HCG, my diagnosis is confirmed. Okay, medullary carcinoma of thyroid secrete calcitonin in the blood. For example, there is a lady in my clinic having a thyroid swelling, and I am suspecting the lady is having medullary carcinoma of thyroid. So I will take the blood sample and look for calcitonin. If calcitonin is elevated in the blood, the diagnosis is confirmed the lady is having medullary carcinoma. So this is how. Pheochromocytoma secrete corticolamine in the blood. So if there is an adrenal tumor, adrenal gland, adrenal medulla tumor on the CT or MRI, I am suspecting pheo. So I will check the blood level. In the blood, if catecholamines are elevated, my diagnosis is correct. In the same way, liver tumor secrete alpha fetoprotein. Cancer of colon secrete chorionic embryonic antigen CEA. Prostate cancer secrete prostate acid phosphatase. Likewise, you have to learn the list. Multiple melanoma secrete immunoglobulins in the blood. Prostate cancer secrete prostate specific antigen PSA. Ovarian tumor CA125 is elevated in the blood. Colon cancer and pancreatic cancer CA19.9 is elevated in the blood, and breast cancer CA15.3 is elevated in the blood. They are more of important for MCQ purpose. You get simple MCQ that CA125 is the indicator of ovarian cancer, CA19.9 is an indicator of colon cancer, CA15.3 is an indicator of breast cancer. So these are glycoproteins. So learn few example, few among hormone, few among antigen, few among enzyme, few among protein, and few among glycoprotein. Divide them and learn at least 5 to 10 examples. So you are asked in your exam as a short question or a very short question, enumerate 5 examples of tumor markers, enumerate 10 examples of tumor markers like that. So you should be able to enumerate it in your exam. The tumor marker with the corresponding cancer. So that is the tumor marker. So that's all about it. I hope you are prepared for all 6 methods of diagnosis of cancer. So if diagnosis of cancer coming as a long question in your exam, write down all 6. Start with the histology, then cytology, then histochemistry, then immunohistochemistry, electron microscopy, and tumor marker. So give an elaborative description of the histological method, write down the steps. Elaborative description of cytological, write down the steps. These 2 are important, and a little bit elaboration with examples of the tumor marker. These 3 you can just enumerate the examples. Okay, that's all about it. Don't forget to have a look on long, short, very short questions with MCQs of this portion given in the notes section as well as question bank. Have a look on that so that you will be prepared for this topic completely forever. Thank you so much.